All right. But the question was that a client is in labor with varying fetal heart rate pattern. And he was asking you the one that should require immediate attention. And the first one was that the fetal heart rate deceleration of 20 seconds. So it decelerated for 20 seconds. Okay. And that returns to baseline in 10 seconds. All right. It returns to the baseline in 10 seconds. So, it says that, yes, the question someone asked, yes, thank you so much, Mr. Franklin. Yes, the question is on the chat box. It says it says that a fetal heart rate deceleration of 20 seconds that returned to baseline. So it decelerated for 20 seconds. And then it returns to baseline in 10 seconds. So the baseline in 10 seconds is decelerated for 20 seconds and able to return to baseline in 10 seconds. At the end of contraction. So at the end of contraction, it returns to baseline. So what does it tell you? So it returns to baseline when? At the end of contraction. So contraction ends, it also ends deceleration. So it means that it is mirroring what? Contraction. And that will tell you that it's an what? Early decel. And you said, oh, no, I should attend to a patient with early decel because it's urgent. Or is it that you couldn't get the understanding of the option? Okay, it returns to baseline at the end of contraction. So there's a mirror. Okay, it goes hand in hand. And option B was saying that fetal heart rate deceleration. This one is deceleration. So you have to know what kind of deceleration. When the question is asked, ask yourself what kind of deceleration, because deceleration, some are good, some are bad. So ask yourself, what kind of deceleration are we talking about? All right. And B says that fetal heart rate deceleration, because it's not every deceleration which is bad. So once you see that deceleration is bad, and once you see acceleration is okay. But no, when is acceleration okay? When is deceleration okay? Fetal heart rate, B says fetal heart rate deceleration of 15 seconds. So it decelerated for 15 seconds. That returns to baseline immediately at the end of contraction.
That's early decel.
This one also tells you that it's an what? Early decel. It's an early decel. And what's the cause of early decel?
Head compression.
What?
Head presentation.
Head compression. And that's normal, as expected during contraction. All right. So know the adjective that's, or the modifying words. Okay, it says at the end of contraction. All right, so please take note of. We've already known that the first two are deceleration. All right, but with varying what? Fetal heart rate. And it says that fetal heart rate accelerations of 10 seconds, lasting 2 to 3 minutes and growing stronger. So there's fetal heart acceleration. When is acceleration okay? When is acceleration okay? Yes. At what point in time do we say that this acceleration is okay, it's normal? The last time I told you. At what point in time? Yes, please. Or you've forgotten? Mr. Matola.
Accelerations of at least 15 beats per minute.
Last 15 seconds.
Is that the only indication that? And this one is at least. The least means that that's the smallest number. So if it's lasting 2 to 3, it means that this falls within acceleration. So when is it okay? Yes.
Last 15 seconds.
Pardon?
When it lasts for 15 seconds.
15 seconds maximum.
20 seconds.
Hey, you've forgotten so soon. Jesus Christ. Madam Poppy, are you there?
Yes, sir,
Yes.
I'm here. Greetings to everyone.
You're welcome, sis. Please help us.
I think acceleration mostly starts when the contractions ends.
All right. That's okay. But we want to know at what point in time do you say it's okay? This type of acceleration is okay. Because acceleration.
When the last
When what?
15 beats per minute and more at the baseline. 15 beats per minute.
15 beats per minute.
Yes.
Okay. This time bigger. Yes.
15 beats per minute. Last 15 seconds.
What?
Yeah, boss.
And lasting
Yes, please.
seconds.
Continue.
Okay, so it's when there's an increase in 15 bits per minute, and I think lasts for 10
Modify
seconds and return.
modify your bit per minute. Modify. We use
Like
some modifying words.
from the baseline, it will increase 15 bits per minute. Like, please, do you understand that?
At least, or
All right. I think.
it's me. What I know
No,
is that.
Yes, please.
What I know is that it should increase from the baseline at least 15 beats per minute, lasting for
10
at least 15.
seconds.
Yes, 15 seconds.
And return to. If you have 15.
Are you there?
Yes.
So, the last time I told you that this
Boss.
is brief. Yes, please.
Okay, so I think the acceleration should be 15 seconds per beat, lasting 15 seconds, and
beat.
should be less than per minute too. Sorry. So it should be 15 beats per minute or seconds, but it shouldn't go beyond 2 minutes. Sorry. It shouldn't go beyond 2 minutes. So it should be 15 less than 2 minutes. If it goes beyond 2 minutes, I think there's a problem.
Exactly what we discussed the last time. At least the least acceleration should be what? 15 beats per minute above the baseline. That's sustained for at least what? 15 seconds.
15 seconds.
But not longer than what? 2 minutes. That's what we call acceleration. So if you look at this point, the graph on the, as you can see, You have acceleration here. All right. And look at the baseline. The baseline is around, so yes, 90, 100. So the baseline is, let's say, around 100. Okay. And once it reaches here, there's an abrupt increase in the heart rate, but quickly returns to the baseline. And then it continues, say, all right. So this abrupt increase, we are saying that for it to be called acceleration, of which the intervention means okay, it means that we should have an increase above the baseline, which is an increase of what? At least 15 seconds, which is lasting for at least 15 seconds, but not longer than 2 minutes. All right. And then quickly returns to the baseline. So please, learning, you might know that, okay, I understand the meaning of acceleration. Acceleration is just an increase. But sometimes, some of the small qualifying words or modifying words are so much important. All right, so once you are learning, learn all these things. Okay, so once you know that I think when we were discussing this thing, someone asked a question about this. That what about if it's a cis that time? Okay, and I explained it to you. So if it exceeds that 2 minutes, it means that there's a problem. How can the fetal heart rate be sustained for more than 2 minutes without coming to the baseline? There's a problem. The fetus is in distress. We need to quickly intervene. So know the modifying words. And once you know that maybe it's a late decel, you know at what point in time for deceleration, at what point in time do we have to intervene? Because you know you have different types of deceleration. But at what point in time do you see that this decel is either late or variable, and you have to intervene? The difference is based solely on the modifying words. I replace okay. So don't just know that variability or variable decel is just that doesn't follow any pattern that comes as a result of cord compression. That's not enough. At what point do you have to intervene? At what point do you know? Because once you know that there's deceleration, at what point do you have to know that this type of deceleration you're having is a complication or it's a serious problem that you have to intervene? Please, you have to know that. Are you please okay? Are you okay?
Yeah, okay.
All right. Thank you.
Yes, sir.
Boss Frank.
Yes, please.
Boss Frank.
Yes, please.
The first one, the first option, I also understood it as it's also a late deceleration because it returns to the baseline 10 seconds at the end of contraction. It means that contraction ended and then 10 seconds before it returns. So it means that it's also a late decel.
Which one?
The first option.
The first option. Okay.
Yes. So is the first option not also a late decel?
Definition of late decel. Are you there? Are you there?
Yes.
Okay.
Yes.
So when we say late decel, look at the word. Point 1, starts. Starts after the contraction ends. And what was the word is used for the answer option A. A typical, we say that, where is the answer? Yes. A fetal heart rate decelerations of 20 seconds that returns to baseline. So this one is returning to the baseline, not starting. Hello, boss. Are you seeing the answer A?
Yes.
This one is returning. So it has sustained for that number of seconds. And this one, it says returning to baseline at the end of contraction. So this one, there's a return, not starting. You get it? You get it? The difference now?
Okay.
So let deceleration starts. The deceleration start decreasing at the end of contraction, but it's not returning to baseline at the end of contraction. If it's returning to baseline at the end of contraction, so contraction has ended and it's returning, it means that it is mirroring. It is in parallel. Okay, that is termed as what? Early decel. But this one starts after contraction has ended, not returns after contraction has ended. So get a difference. I hope you are okay.
Yes.
Okay.
Hello, that's fine.
Yes, please.
Please, with the question that a police just asked, that is how Mr. was seeing the whole thing, because it looks like in the question it was just projecting how the contraction ends. So with what you just projected, the late deceleration returns to baseline after contraction ends. So that is where the question was taking its line. And the question too was like after 10 seconds. I don't like it says that Peter has rate deceleration of 15 seconds. That returns to baseline immediately at the end of a contraction. So that returns to baseline. Hey, sorry, where am I even reading? The A returns to baseline in 10 seconds at the end of the contraction. It was just focus. It was just focusing something like your definition for the late deceleration when it comes.
The whole thing is the major difference is returning and starting. Please, let's take note of that. Returning and starting. That's the major difference in this scenario. Note that deceleration, it start going down, the heart rate start going down once contraction has ended. Not contraction, heart rate returning to baseline at the end of contraction. Not that. That one is a classical sign of early decel. Early decel returns at the end of contraction. So once it's returning at when? End of contraction, it means that once contraction ends, that's where the base is returning to baseline. And that's a classical sign of what? Early decel. But late decel, the deceleration starts after. It doesn't return at the end. When it is returning at the end, it's different from starting after the contraction ends. Do you understand? Are you okay? Are you there?
Yes, boss.
Okay. All right. So one thing you should know about it.
Boss Frank.
Yes, please.
Please, where was this question posted?
It's a general page. One of our general pages. Are you not there?
No, I don't even know about it.
You don't.
I'm only on the Elites master class.
Is that so?
Yes, please.
Okay. Send any of the bosses your number, okay, and they will add you to the page, okay.
Okay, thank you.
The question has been posted in the chat here as well, so you can look it up there.
Yes. So know when late deceleration starts. But okay, it starts or once contraction has ended. That's where we see deceleration. Okay, that's what you should. And apart from that, when we have deceleration, late deceleration, we've already known the cause as well as results of what's the name? Uteroplacental insufficiency, right? So that's what you should know. Either the placenta is not is not able to supply the fetus enough blood. All right. Either there's preeclampsia, either there's hypertension or hypo. Any of them can result in that. Because if there's hypertension, there's vascular constriction. If there's hypotension, there's decrease in cardiac output. All right. So any of them can lead to that. And when there's post-term pregnancy, with post-term pregnancy, we know that the what's the name? The placenta starts detaching itself from what? The wall. Okay. So that one can also lead to that. All right. So we are looking at variable decel. I think last time we talked about it. With variable decel, we are saying that there's abrupt decrease in fetal heart rate. Decrease in fetal heart rate. But this one is purely as a result of cord, umbilical cord compression. And this one, know when it can happen, before, during, and after contraction. All right. But the shape is irregular and drops occur in what? In less than 30 seconds. Okay, that's why it's abrupt, something brief. Okay, and decrease of 15 beats per minute, lasting for at least 15, but less than 2 minutes. That also for variable. They all last less than 2 minutes. Okay, and it goes with as we've already known about the intervention. This one also the same. Lion. Okay, if there's pitocin running, just have to stop because there's cord compression. All right, and you have to what? Release or stop compression. So if there's pitocin or oxytocin ongoing, you have to stop. All right, and once you stop that, that's your priority. That's your priority. If pitocin is ongoing, you have to stop. And once you stop, you place the patient in sideline or knee chest, and you administer oxygen. And this one is via face mask. All right. And you know your vitals, you increase fluids. If it's fluid, you have to assess for prolapse. Because variable decel is purely cord. You notify your healthcare provider, and you can also give amnio infusion, okay, with saline. Okay, but you have to do the non-invasive, you take the non-invasive actions first. Okay, amnio infusion, infuse with what? Warm saline, sterile one. Okay, because there's cord compression, so that because we noted that with variable decel, oligohydramnios can be a cause. All right, so that's what you should know. And we have the sinusoidal pattern. Okay, the sinusoidal pattern. With this one, we said it just it has a smooth wave-like pattern. Okay, no variability here. It's like this one is similar to let me show you so that you will see it. Let me show you over here. Can you see it, please? Can you see my screen?
Yes.
please.
Yes, sir.
Yes. So that's what is meant by sinusoidal. Okay, sinusoidal pattern. So once you see what's the name? This pattern, just know that it is sinusoidal pattern. And this one is dangerous. Okay, it's dangerous. It's like patient having a late decel. It's dangerous. All right. With all the deceleration, if you see late decel, you have to attend to that patient. If you see a sinusoidal pattern, you have to attend to that patient because this one may indicate that there's a fetal compromise. Okay, there's fetal compromise. So this one, there's that smooth wave like a sine wave. Those who did maths, see a sine wave. Okay, a sine wave, and this sine wave pattern that you see is what called sinusoidal sine wave, sinusoidal pattern. You see that it's regular and it's repeating the same oscillation. Okay, regular repeated patterns of oscillations, as we can see. All right, so that's what this one there's no what's the name, variability here. It has that smooth wave like sine wave pattern, okay, with repeated what oscillations. All right, that's what you should know. So once you see that, we quickly have to know that this is a sinusoidal pattern, and this is very serious that you have to attend to the patient. All right. Are you please okay? Are you okay?
Yes, sir.
Okay. So this one, know that there's no variability, there's no acceleration. It just the sine wave oscillating, repeated oscillations. So once you see repeated oscillations in the same pattern, okay, no accelerations, no variability, this one is dangerous. Okay. This mostly will indicate that there's fetal distress or fetal hypoxia or anemia. Okay, this one is may indicate anemia. So when the fetus is having anemia, this is the kind of heart rate we are going to see. All right, please, okay. If you're having anemia, for example, if the mother, we've had what's the name? RH incompatibility, okay, which leads to fetal anemia. All right, we maybe we are having fetal maternal hemorrhage. You are having hemorrhage. It's going to result in that. All right, please, okay. So if we have fetal anemia, we can have this kind of pattern. And this one is serious. All right, that's what we have to know. Okay.
So, boss, please, in between this one and late distal, which one is more dangerous?
In between sinusoidal and late.
Yes, please.
Okay. Class, what do you think? Yes. Yes, please. Are you here?
Yes, sir.
What do you think? Sinusoidal. Okay. Any other?
Sinusoidal.
Sinusoidal.
Thinking
Okay.
that late distal can be because of the causes, because we have this maternal hypoxia, and when there's hypoxia, I mean that hypertension and preeclampsia, all this, you have placenta. The complication for this late distal too is much, It's, for me, late distal.
Okay. Any other?
Yeah, I think it's the sinusoidal.
You think it's sinusoidal?
Yeah, because you
Okay.
said that one hypoxia and the lady said at least they are getting some. It's just that it's insufficient, right?
Okay.
It's not.
All right. So know that both either sinusoidal and what's the name? Late distal. They are more dangerous. They are all dangerous. And they all require immediate intervention. You understand? So that is what you should know. But one thing is that with sinusoidal, it's something which it doesn't occur frequently. Unlike what's the name? Late distal, which mostly occur. Sinusoidal is very rare. Okay, it doesn't occur frequently. But note that they're all dangerous. They're all dangerous. And once you see this, both you should attend to them. Do you understand, please?
Okay, thank you so much.
Yes, all dangerous, yes. So mostly if let's say on the NCLEX, they want to distinguish or the one that you should attend to it first. Mostly they won't bring these two together. Okay, they won't bring these two together. Right? They either bring late distal together with other type of decelerations or accelerations, or with sinusoidal, they will bring it together with other types of decelerations or acceleration. Do you understand, please? Because the main cause, as we are saying, this sinusoidal can be that there's maternal hemorrhage. The patient is hemorrhaging, or can be anemia, or it can still be that there is what fetal hypoxia. Okay, which of course all of them can be as a result of fetal hypoxia. So they are all the same. The danger is the same. I hope we are okay. All right. So it could be that if, as I told you, when there's RH incompatibility, okay, RH incompatibility. But looking at this issue, if you have RH incompatibility, patient is having RH incompatibility, mostly you have to quickly deliver. The same thing when it happens when the patient is having a late distal. Okay, you have to quickly intervene and deliver. Are you please okay?
Yes, please.
Okay. So what's the way forward? Immediate what? Delivery. Are you okay, please? Immediate delivery. So that's what you should know. Okay. When we have sinusoidal pattern, the best way is to deliver. Is to quickly deliver the patient and intervene. Quickly deliver. Okay. So that's what you should know. All right.
Hello, so boss Frank.
Yes, please.
So please, are you saying that the lion doesn't apply here?
Which one?
The sinusoidal, are you saying that the lion management before the delivery is not applicable?
When, in terms of NCLEX, your priority is to deliver, not to use the lion over here. Okay. Your unless if let's say there's a drug ongoing, you have to caution that. We have to stop the drug. But apart from that, your priority is to deliver, not the lion. That's why we don't intervene and let's say we don't have to do some intervention and you watch and wait. Okay, you have to quickly deliver. Okay, so that's what you should know. In sinusoidal pattern, you quickly deliver. You don't have to place the patient in left lateral position. No, prepare for delivery. Prepare for delivery.
Okay, thank you.
All right. So if you see that there's variable D cells, okay, when there's fetal heart rate repeatedly, that recurrent decline to less than 70 beats per minute, that's concerning. This one is severe bradycardia. Okay, you have to intervene. Or if it persists at least for 60 seconds before returning to baseline. Okay, so we have to also intervene by preparing for surgery. Okay, all right. Which clinical findings can be determined only by electronic fetal monitoring? Tachycardia, variability, bradycardia, fetal response contractions. Yes. Which of them?
B.
Yes, class.
D. D.
Fetal response to contractions. So once there's contraction and the fetus respond, you're going to use the electronic fetal monitor to see. All right. Any other? Some are saying D, 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 D. I'm sorry to tell you that that's not the answer. Okay. So variability, where we are going to see. We use the variability. That one, fetal response to contraction, how the fetus is responding. This one, electronic fetal monitoring. We monitor the heart rate. In the heart rate, what it monitors is the variability. Variability. Either we are having marked variability, moderate variability, or absent variability. All right, and that will be seen on the monitor, not the fetal response. All right, please, okay. Okay. The nurse is monitoring a client in labor who is attached to an electronic fetal monitor. The fetal heart rate tracing shows baseline heart rate of 130, so that's the baseline, per minute, with fluctuations of 6 to 25 around the baseline. No decelerations are noted, and accelerations occur with fetal movement. Which action by the nurse is most appropriate based on these findings? A, immediately notify the healthcare provider of a non-reassuring fetal heart rate pattern. B, position the client onto her left side and apply supplemental oxygen. C, document the findings as normal reassuring pattern and continue to monitor the client with routine care. And D says prepare the client for an emergency seizure due to marked variability. What's your answer?
C.
Quick. Then?
C. Document the findings as normal.
You are having C, you are having B. Any other? B says reposition on the client and give supplemental oxygen. Why do you think giving supplemental oxygen is important here? Why? Why do we think oxygen is important here? Yes, please. Why do we think? Obviously, there's no cause for giving oxygen.
Emergency.
6 to 25 is what?
Normal.
What kind of variability is that?
Moderate
It's
variability.
moderate variability.
Moderate variability. And moderate, that is okay, true or false?
It's true. And the heart rate too is normal. The baseline heart rate is normal.
Yeah, baseline is 130, and then it's fluctuating. That's okay. And then fluctuation is okay. 6 to 25, that's moderate. Okay.
There's no deceleration.
Yeah, there's no decelerations noted here, and accelerations occur with fetal movement. Once the fetus moves, we have acceleration, and that is expected of an a fetus with what? Neuro active there's enough oxygen supplying the fetus. All right. So there's no issue of giving, there's no cause for giving oxygen here. All right. Are you clear? Okay, please. So routine nursing management and documentation are appropriate actions here. There's no cause for alarm. The nurse is assessing the client in the second stage of labor, which findings should be reported to the primary healthcare provider. Select order that apply. A sustained fetal heart rate of 170 beats per minute, early decelerations, variable decelerations. The client feels the urge to push. Second stage of labor. You try contractions every 2 to 3 minutes. What are you supposed to report? Yes, please.
A sustained fetal heart rate of 170 beats per minute.
That's what we are going to report. Is that
Nah.
only?
Yes, and variable deceleration.
Okay, so,
variable.
So I think
deceleration.
E2 should be part.
Client feels air to push. Second stage. Okay.
It's normal.
So second stage, when the client feels the air to push, report, right?
No.
No.
So what we
No, it's
Okay.
normal.
All right. So
say, so that would be
okay. So the answers are out.
A and C.
Sustained fetal heart rate. Sustained fetal heart rate of 170 early diesel variable. Sustained can be a sign of what?
fetal compromise.
Fetal distress.
Yeah, the fetal is compromised, fetal distress. Okay. Early diesel, is it okay? Is it
Yes,
Yes.
expected?
early diesel is
Yeah.
fine. There's nothing wrong with it.
And variable diesel, is it expected?
No, it's questionable. You need
No.
to report.
Variable diesel means there's what?
God.
It,
Cord compression.
mm,
And the air to push is normal. Second
Normal.
stage,
yes.
you should have an air to push.
Come and sit here. Because she don't be doing certain silly things, lah.
Sister,
Don't be doing
where
certain
the
silly things. Don't you know you can hurt him?
sister, where the crashy? Sister, where the? All right. So, and contractions of every 2 to 3 minutes. Is it not normal?
It's normal for
Normal
second stage.
stage.
That's normal.
For
The second
second
stage.
stage is normal.
All right.
So
So,
please, which one
Victor,
is not normal in terms of the contraction? Maybe if it exceeds what or less than what?
which one?
Please, the DE, uterine contractions every 2 to 3 minutes. So at which point do we say it is not normal?
Okay. I think last time we explained this to some extent. Who can help us? Yes.
We talked about the normal contraction that it can exceed 90 seconds and ideally it should be 60 seconds.
Mm-hmm.
Please, I didn't get that. Can you repeat, please? Sorry.
Our sisters,
Oh,
they are saying repeat.
I said last time we're saying that the normal contraction should not exceed 90 seconds. So it should be at least 60 seconds.
Okay.
So yeah, boss Frank.
Yes, please.
The contraction, it depends on the stage of the labor. And
Mm-hmm.
yeah, and looking at the second stage, 2 to 3 is okay. It shouldn't occur more closer than 2 seconds. Then it shouldn't last more than 90 seconds.
Okay.
Every 2
So
minutes. 3 is
one thing is
okay.
that you have to know that we have what we call duration and what? Frequency. Is that not it? We have duration
Frequency.
and frequency. This one, when you talk of frequency, it's basically mean the number of times it occurs. Okay, that's frequency. Maybe every 2 minutes there's contraction. Every 3 minutes there's contraction. That is frequency. Is that not it? And duration is when contraction happens. When contraction happens. For how long does it sustain?
Oh, okay.
Maybe contraction has started. For how long? Contraction. For how long should we come to should we have no contraction? It should be sustained for how long? That's what we are looking at. If contraction exceeds number of times, there's a problem. And that, as someone was saying, it depends on the stage of labor. You should know that we have, let's assume labor has just started. Once labor has just started in the second stage of labor, okay, we shouldn't expect that contractions should be so frequent. Okay, like having 2 to 3 minutes, every 2 to 3 minutes there's contraction. That's not early sign of labor. It's not so frequent like that. Okay. We are saying that although signs of true labor, there's what? Frequency of what? Contraction. It has a pattern. But the frequency over here, I mean the timing. When we have early stages of labor, let's say labor has just started. If you are experiencing every 10 minutes, you see contraction, that's normal. For early stage, or every 5 minutes, you are seeing contraction, that's normal. So within 5 to 10 minutes, in early stages, you are seeing contraction, it's normal. All right. And that's if contraction starts, for how long should it sustain? Maybe contraction has started. Now, 30 seconds, there's still contraction. 45 minutes, there's still contraction. That's okay. Okay. As you reach the end of labor, that's where duration prolongs. Do you understand? Because duration of contraction has to prolong so that it can expel the baby. I hope you understand what I'm saying. Or I'm confusing.
No, sir.
We understand.
Yes. So let's assume that, let's take this. If you have started, now labor has just started. Once it's the beginning of labor, the frequency should prolong. So maybe you've just got contraction now, which sustained for about 45 minutes. It's normal for early. In the next 10 minutes time, you are seeing another contraction, sustained about 30 seconds. It's normal. In the next 10 minutes or 5 minutes or 8 minutes, you are seeing another contraction. All right. As the baby descends and delivery is imminent, the duration should lengthen and the frequency should be and the baby is just coming out. That one, the duration, the frequency should be every 2 to 3 minutes. So every 2 minutes, there's contraction. Every 2 minutes, there's contraction.
Boss,
And when, yes, please.
please, your line breaks, so I didn't hear what you said about
What I'm
the
saying that
contraction.
I thought it was from my end, though.
What I'm saying that during, let's say, the transition phase, okay, where the baby is just coming, at the verge of coming, all right, that time, the frequency should be shortened. So like every 2 minutes, there's contraction. Every 3 minutes, there's contraction. You shouldn't exceed that, okay? The frequency should be what? It should be frequent, all right? So every 2 minutes, there should be contraction. Every 2 minutes, that's the point the baby is what? Coming. So every 2 minutes, there should be contraction. That is the transition phase. If you reach that stage, the duration should be longer because contraction has to sustain for such long so that the baby can be expelled. All right. So the duration in that stage should be maybe around 60, should be sustained for about 60 seconds to 90 seconds. There should be contraction. It shouldn't exceed 90 seconds. When contraction exceeds 90 seconds, what will happen? Because note that whenever there's contraction, there's deceleration. I hope you know that. And contraction, prolonged contraction, will cause the baby to have what? To become, to have respiratory compromise.
Hypoxia.
Yes, hypoxia. Because contraction will constrict the blood vessels, decreasing blood flow to the child. So the duration shouldn't exceed 90 seconds. That's when you are reaching the transition phase of labor. I place okay.
Mm.
Are you okay?
Yes, please.
Mm-hmm.
Thank you.
That's what you should know. All right. So during the second stage, so this one has combined the early stage, the what's the name? The active phase as well as what? The transition phase together. It has combined all. So it has named second stage. So with that second stage, we should have that number of contractions. So every 2 to 3 minutes, contraction is okay. When it's beginning, when a woman starts experiencing labor, the duration should be around, the frequency should be around 5 to 10 minutes. Every 10 minutes, there's contraction. That's okay in early stages. All right. So we've already discussed this one, Vilchop. Variable means chord compression. Early means head. Acceleration is okay. But when do we say acceleration is not okay? Yes. When do we say, when can we boldly say that this type of acceleration is not okay?
When it's more than 2 minutes.
When heart rate sustains for more than 2 minutes. Okay. Very good. Any other?
Or when the acceleration is a marked one.
Marked acceleration over 25.
When there's marked acceleration. Okay. All right. So note that acceleration itself is okay, but all depends on the time. But the question we solved earlier on, we are saying that fetal heart rate that return to baseline at the end of contraction. Sorry, not that one. Fetal acceleration that returns to baseline at the end of contraction. Look at the description. Fetal heart rate that returns to baseline at the end of contraction. Is it good or not? Is this type of
It's good.
acceleration good or not? Is
It's
what?
good.
It's good.
Good.
Okay. Look at another acceleration. Fetal heart rate accelerations of 10 seconds lasting 2 to 3 minutes and growing stronger by 10 seconds per cycle of contractions. So every contraction, the minutes prolongs by 10 seconds more. Is this type?
It's bad though.
It's bad. And this one can cause what?
Fetal
Fetal
hypoxia.
hypoxia. Because when contraction is so strong, more than 2 minutes, and we say that contraction shouldn't exceed in even the transition phase, shouldn't exceed 90 seconds. So if there's that strong contraction, okay, which is lasting for that 2 minutes, and this acceleration is lasting for 2 minutes, it's bad. Okay, this acceleration lasting for, it should be less than 2 minutes. So if it's lasting more than 2 minutes, it's a problem. So know when acceleration becomes a problem and know when it's good. But in general, acceleration itself is okay. You should have accelerations in fetal heart monitoring once you are using the monitor. Okay. So late deceleration is bad. Okay. So with these things, early and accelerations are okay, but the rest are bad, which needs intervention.
Sir,
Okay. Yes, please.
please, with the C, no. If you check a contraction shouldn't exceed 90 seconds. So when you read the answer and growing stronger by 10 seconds per cycle, meaning that 10 seconds have been added to the 90 or what? I want to get that one.
He said that fetal heart rate acceleration of 10 seconds. So 10 seconds. Okay, it's accelerated for 10 seconds.
Okay. Instead
Lasting
of
for
90.
2 minutes. So let's say the baseline is 130, and then it goes to 140, and it'd be at 140 for about 2-3 minutes, and growing stronger by 10 seconds. So there's ongoing period, growing stronger by 10 seconds per cycle of contractions. So at every contraction, there's also an increase of what? Fetal heart rate. 10 seconds more. So
That's what I wanted to understand.
yes, if the first one was, let's say, from baseline of 130 to 140, another contraction, it will increase to 140 and 150. So it's growing. Do you understand? Every cycle of contraction, it grows. So the heart rate increases per every cycle of contraction. And it's sustained for that 2 to 3 minutes, and that becomes a problem. I hope you're okay.
Yes, please. Thank you.
All right. So that is the whole thing about future. All right. All right. Umbilical cord polyps. That's our next topic. Umbilical cord prolapse. And that is when we are having what type of deceleration?
Late.
Are we sure?
This is variable diesel.
Variable.
It's variable diesel.
Very good. Variable. Cord, middle. Variable. Late is the what comes last? The placenta.
Placenta.
All right. So once you see yes. So this one is cord. Variable. Okay. When the umbilical cord slips ahead of fetal presenting part. So if the head is presenting, the valve is presented. Once you open that place, what are you going to see first?
The cord.
The cord. All right. So that is what we are looking. We are terming it as what? Umbilical cord prolapse. The cord has prolapsed. That's protruding, coming first. Okay. So that one enters the birth canal before or along the fetal presenting part, and often occurs with membrane rupture, because if there's no membrane rupture, there's no way you're going to see the presenting part. So always take note that membrane rupture precedes the presentation. Are you okay? Are you okay, please? Membrane rupture precedes presentation. All right. And this can compress the cord, causing decreased blood flow and oxygen to the fetus. Because once there's cord compression, it means that it's going to decrease blood flow to the fetus, and it will lead to fetal hypoxia. That is all that we mean by umbilical cord prolapse. And that is a medical emergency. So now we've started with all the medical emergencies in maternity. Are you okay, please? So note that umbilical cord prolapse, if you are attending to a patient or the person asks you to choose one option which will be your priority, umbilical cord prolapse is also part of it. Sometimes you may not get straight forward question like umbilical cord prolapse. You will see that the umbilical cord has slipped ahead of fetal presenting part. And once you see that, something should tell you that it's umbilical cord prolapse. All right. And what are the signs of umbilical cord prolapse? the signs. Number one is what?
Addition.
May feel something in the vagina. Visible umbilical cord. And once we have that, we call it overt. Something that is visible, overt. Okay. So overt means that it's visible. You can see it. All right. So you see something in the vagina, that is in the birth canal, and usually there is no pain because it's the baby who is going to suffer, not the mother. So note that umbilical cord prolapse doesn't come with pain. Take note, it doesn't come with what? Pain, because it's the baby who is suffering. Because all this thing is the baby is going to suffer, not the mother. Okay, not the mother. So umbilical cord prolapse, know that the baby is going to suffer, so the mother won't experience any pain. But the only thing is that there's pressure down there. Okay, may notice pressure. There's something that's because it's like the head coming. If the head is coming, it still sees some sort of what? Pressure. That's a normal sign of what? The baby passing through the canal. Okay, and that is what you should know. And with the fetus, what are you going to see on the monitor? Variable, because it's called, or bradycardia on the fetal monitor. And there should be, when you are monitoring a client, and suddenly there's a fetal decrease, there's a decrease in fetal heart rate, please, that is your hallmark of cord compression. Sudden decrease in fetal heart rate. There's nothing happening to the mother, the fetus. We have baseline variability, moderate variability. Okay, while the baby is coming, you are just monitoring, you're looking on the monitor, and suddenly you see a drop. Bradycardia. Quickly, we have to assess. So if you see a sign on the monitor, we don't intervene. True or false? True or false?
You
Yeah.
said if we see a sign on the monitor.
We don't intervene.
Please,
We
we didn't
assess.
hear.
When we see a change in sign, a change from normal on monitor, what do? You assess. You assess first, because your patient first, not the monitor. The monitor can be a mistake. All right, there might be a problem with the monitor, so do assessment. If you see any change in any monitoring device, your first thing is not to intervene. Assess. That's why sometimes you see a question. You're monitoring a patient, and on the monitor you see a systole. What would be your priority? Is it to initiate compression?
No, as patient.
You assess your patient. I hope that makes sense.
Yes, sir.
Okay. Always assess your patient. If there's a problem on the monitor. All right. And where are we? Yes. So you have to do rapid recognition of fetal distress. Recognize, assess for it. That's your priority here. Okay. So that is it. Your priority here, look at the word. Your priority is to relieve what? Cord compression. Relieve the cord. Right away, relieve the cord. Don't go and hold the relieving the cord doesn't mean that go and hold the cord. Are you okay? Don't go and hold the cord. Holding the cord, you are putting more pressure on the cord because already there's compression on the cord, and you're also holding. At least there'll be some sort of compression as well, which will further decrease the heart rate. So, relieve cord compression by doing what? Elevating the presenting part. Will you have to? Okay, let me ask you. Is it okay? What if you are a midwife or a nurse assessing a patient? You see a patient with cord prolapse. Is it okay to push the head back? Go to where you are coming from.
No.
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 Are you not relieving the cord?
Yeah, you lift the presenting the part on the cord, you lift it up.
Yes. So please don't go and push the baby back. The baby is coming. Let him come. Okay. We only have to lift. Elevate the presenting part. Don't go and hold your cord. So the part that is lying on the cord, by applying what? Finger pressure with sterile glove, not normal surgical glove, not your bare hand. Please have sterile glove. We don't want to complicate things. We don't want to have infection. So your hands should be gloved, okay, to relieve the pressure. So only your hand, finger pressure on the presenting parts, you lift or you elevate with sterile gloved hands. All right. Once you do that, you place the mother in chest position, chest knee position. Knee chest position. Okay. Or what? Trendelebe. I hope the last time I explained to you this kind of position, right? I hope you remember.
Yes, please remember.
Knee chest. Because once you place the patient in knee chest position, the baby will, in one way or the other, will move backwards, so that the pressure on the cord will be relieved. The same way has to do with Trendelenburg. Please note, not a reverse Trendelenburg. Trendelenburg. What is Trendelenburg position? How is it like?
The head is slightly down than the body.
Yes.
So the patient will lie left lateral or left Trendelenburg position with the head slightly down than the body.
All right. So that is it. I hope you're okay. And the next thing is, once you lift the presenting part and you place the mother in knee chest or Trendelenburg position, please don't leave the mother and go and call.
You stay.
Hello. Are you okay? Don't ever leave the mother, because to die from oxygen takes seconds. Okay, so never leave the mother to call for help. Look at the word. Don't leave the mother to call for help. Are you please okay? Are you okay?
Please.
Yes.
Okay. So that's what you should know. Okay. And another thing is that avoid supine positioning. That's what this one is very common thing in maternal pregnant people. We avoid supine hypertension and stay with the client. That's very important. You call for assistance. Let another person notify the healthcare provider, not you. All right. Administer oxygen, because there's decreased blood flow, there's decreased oxygen. So you have to administer oxygen. You wrap the cord loosely. Look at the word, loosely. Wrap. You wrap in what? Sterile towel, which is saturated with warm saline. Why do you think this action is important? Yes. Why do you think this action is important? Mr. Matilda.
Avoid dryness of the cord.
To avoid dryness of the cord. Very good. Another reason.
It
To
should
prevent
prevent the
infection.
yes,
To prevent
infection.
infection.
To
Okay.
also
Yes.
maintain supply,
To
oxygen
do what?
flow. Also to
Blood flow.
maintain the
Yes.
blood flow for the
Very
baby, the
good.
future.
Very good. So that is it. Okay. But
Okay.
please note the word. It should be saturated in warm saline. Warm, not cold. Warm saline. That's very, very important. Warm saline. And the towel should be sterile. Everything that touches the cord should be sterile. Either your hand should be sterile, either glove, sterile, what if towel, sterile, saline, sterile, not just normal water. Everything that touches cord should be sterile. Take note of that. And you have to monitor your heart rate as well, because there's fetal deceleration. So monitoring heart rate is also important. Okay. You notice if there's hypoxia, and we give fluid, because in any decel, we have to give fluid, with the exception of the normal decel. Okay. So in any decel, you have to give fluid. So administer IV fluids. If there's oxytocin ongoing, you have to stop, because oxytocin will put more pressure. So in cord prolapse, pushing is avoided, because once you push, it will further compress. We rather relieve. In cord prolapse, pushing is avoided. So don't tell the mother to push. All right. So
But
yes, please.
so because what you said now, I was thinking about it. You see, the contraction and the urge to push comes naturally. So how is the woman going to be able to withhold the pushing? Because the urge will be coming and the contraction too will be coming. So I was imagining in a real case scenario, how is it going to be prevented?
Okay, that's a good question. I hope this one day we can all help, right? Who is helping? Our midwife here. Who is helping? Some people are not talking, please. I know you.
Well, Frank, I'm not a midwife, but I want to try.
Okay.
What I've seen is that when they want to avoid the woman from pushing or the mother from pushing, they will usually tell the mother to breathe through the mouth. So the mother not making an attempt to push as against pushing would rather cause so if the mother is pushing it to further put pressure on the cord, but if the urge to push is there and she's breathing through the mouth to prevent the pushing, it will help a little rather than she consciously trying to push because she feels the urge. That is what I think.
Okay, thank you, sister. Any other submission? Any other? Okay, so that's basically that. The edge is although there, all right? So we have to find a different way of avoiding pushing. The edge is there, all right, no doubt, because contraction is ongoing. Okay, that's why in this case, if you are inducing or if you are augmenting, you have to stop augmentation. All right, so you have to stop oxytocin, pitocin. Stop it. All right, and once you stop it, it will further relieve the contraction. Okay, and if the mother is going through normal delivery without any augmentation, just find a way by letting the mother breathe through the mouth. Okay, and that will also help in preventing the mother from pushing. Are you please okay? Are you okay? No.
Yes, boss.
Please,
Thank you.
will
I'm okay.
positioning the mother also help?
We will do what?
Like reposition. Reposition, like you let the mother lie on the lateral side, left. So that also help.
Left lateral. You know, we want to reduce compression. Okay, lying in a left lateral is not the best. If, let's say, lying in Trendelenburg or knee chest position will be problem, that's the last resort we can go.
Okay.
That's how far you can go. But the best position to relieve cord over here, that's why our priority is to relieve the cord. To left lateral position is okay, but only when the mother cannot assume the knee chest or Trendelenburg.
Oh, okay. Thank you very much.
All right. So in cord prolapse, there are don'ts in this scenario. We don't push the cord back into the uterus because the cord is already outside. We don't want to cause infection. It's already exposed to bacteria. All right. So you don't want to cause what's the name?
Sepsis.
Yes, you understand. And we also don't want to further cause compression. And we don't leave the patient supine. Note that it wasn't compression. We don't delay intervention. You have to gather all your equipment, your gloves, your sterile gloves, your warm saline, okay, your towel. Okay. Do not attempt vaginal delivery. This one is contraindicated. So when a question is asked, which one is appropriate, which one is not appropriate, which one is contraindicated, this one is part of it, the contraindication. Pushing and vaginal delivery. Unless you anticipate rapid delivery, but generally it's avoided. Do you understand, please? Generally it's avoided unless you know that, oh, just in about just less than 1 minute time, the baby will come out. All right. But if it started right from rupture and you see the cord prolapse and then contraction, which has started, which can take up to 1 hour, 2 hours, and you are saying you are anticipating vaginal delivery, that is a blunted lie. Okay. So please take note of that. Are you okay? So pushing, as I said, is totally contraindicated. It's contraindicated, not necessary. It's not a necessary thing. It is contraindicated. Do you understand the differences?
Yes.
Hello?
Yes, sir.
Say
Yes, please.
Yes, sir.
So don't go and choose not necessary. It's contraindicated. Contraindicated. All right. Another emergency thing. Shoulder dystocia. Okay. The shoulders, especially the anterior shoulder, the anterior one, the one that comes first. Okay. The shoulder that presents first. That's what we mean. The anterior shoulder gets stuck behind the maternal pubic symphysis. Okay, it's not coming. So this one too, pushing is avoided, is contraindicated, preventing the baby from being delivered. Okay, so the shoulder is like a turtle. You know turtle, right? Turtleneck. So what are some of the risk factors? When the mother is having diabetes, sometimes they will present with macrosomia babies. I hope you understand macrosomia babies. Macrosomia.
Big babies.
Yes, sir.
Yes. With macrosomia babies, big as a result of diabetes. So the baby is stuck in the pubis, symphysis pubis. Okay, it's not coming. Obesity. You are so big that pushing becomes a problem. Okay. We have a postpartum. They are not flexible. They have already grown. Some of them they have beards coming. All right.
Post-term. Oh,
Yes. Post-term. They have already beards coming. So they are not flexible enough to maneuver their way through the canal. All right. And when you have a previous history, and short stature too becomes a problem. All right. Because we need a wider pubis, okay, so that the baby can come. So when we are a short stature, will predispose you to getting shoulder dystocia. The shoulder is locked, and excessive weight gain in pregnancy. So those who have been eating, eating is good. Eating is when you are eating. Please reduce the amount of food that you are taking, because excessive weight gain can predispose you to shoulder dystocia. Okay, so that is what you should know. Are you please okay?
Yes, sir.
Okay. So, what are you going to see in shoulder dystocia? We have a sign called turtle sign. Do you know turtle? Do you know turtle?
Yes.
Yes.
Mm-hmm.
The
See
tortoise.
is that? What did he say? So
Tortoise.
yes, you only see the head. With turtle, we only see their head. Okay. Sometimes, especially if they are in danger, they will just withdraw their head. But if they are just coming, just want to maybe start going, you see that they only protrude their head first, and the shoulders are locked in the case. Okay, so that's what we call turtle sign. So turtle sign, once you see turtle sign, just know that it's like shoulder dystocia. With shoulder dystocia, you only see the fetal head, but the first shoulder, which is the anterior one, is not even coming. Not to talk of the posterior. Okay, so you only see the head has been delivered, all right, but the anterior shoulder can be delivered. All right. So, and once it happens like that, so sometimes you see that there's retractions. The head comes and goes, Okay. And that's what this one will predispose the mother to what we call prolonged delivery. Okay, or delayed. So delayed delivery, shoulder dystocia can be a risk factor. Delayed or slow delivery of shoulders after head. Okay, so the head is delivered all right, but the shoulders will take long hours before you can deliver. And we have asymmetrical head to body movement. Why? Note that we have asymmetrical, not symmetrical. Normal baby, when you deliver them, you should have the side of the shoulders should be the same level. But if they have shoulder dystocia, after delivery, you can see that one shoulder is longer than the other. You understand? And mostly that is as a result of maybe if there's an injury. That's what's the name? Plexus injury. Okay, so that is what you should know. if there's an injury, you're going to see that one side of the shoulder is longer than the other. So that is what we call asymmetrical head to body movement. And most this one, when there is asymmetrical head to body movement, okay, it will also be a predisposition factor to the mother having what? Prolonged delivery and fetal distress. You see that the baby is not is in distress. Why? Because the head is delivered, but it's not coming. All right. So it will be a sign. And maternal or fetal tachycardia. Distress will produce tachycardia. The mother is already exhausted because it's pushing, contractions ongoing. The mother is already tired. The heart rate will start going up. Okay. Abnormal or contraction pattern. And with the mother, she will have difficulty delivering with even usual traction. Are you okay, please? How do we intervene? With this one, we perform what we call Mack-Roberts maneuver. Let's see how that one looks like. Sorry, I think my network went off. All right. Can you please see my screen?
Yes, sir.
You see that the mother is lying down, and then the shoulders, sorry, the guy has lifted the what? The leg, okay, the thighs, okay, and will move the knees towards the abdomen. The knees are moved towards what? The abdomen. And then the other leg will be flat on the bed. Just to what? To widen the perineum. Are you please okay? So once the perineum is widened, because the what issue is that if the perineum is so small, okay, the shoulder is locked there. So we have to relieve the anterior shoulders by what? Raising the thigh and pointing the thighs to the abdomen, so that we are going to have a wider perineum to relieve the pressure on the shoulder. Are you please okay?
Yes, sir.
Yes. That is Mack-Roberts maneuver. Okay, Mack-Roberts maneuver. So as you can see here, just to relieve the the pressure, the shoulders. Okay. All right. You see it?
Okay. Legs that are flexed towards the abdomen.
Is that?
Is it both legs that are flexed towards the abdomen?
It can be done in that way. Okay. Or even one leg. But it's wherever we are looking at the anterior shoulder. Because it's the anterior shoulder that is locked inside. Okay. So we want to relieve that one. So that one, by raising the where the if it's, let's say, the right leg or the left leg where it is locked, you have to what? Raise that leg and point the thighs towards the uterus or the abdomen. Okay, and that one will relieve the pressure. I place okay. And this one is non-invasive. It's
Yes.
non-invasive.
Yeah, please. Can we have instances that both sides will be locked?
Both sides will be locked. You know, in normal delivery undergoes a process. We have head delivery, rotation, internal rotation, external rotation, restitution. We have that process. You understand? So always the anterior shoulder comes first. In delivery, when it undergoes rotation, the anterior shoulder will also present first. That's where we have to relieve the pressure, because once the anterior shoulder comes, the posterior shoulder can easily follow. Are you please okay?
I'm okay, but I want to understand that. In terms of delivering, can we have both sides of the anterior shoulders, both right and left being locked? That's what I want to understand.
Yes. Once the anterior one is not coming, posterior cannot come, because the anterior is always leading. So if we are not delivering the anterior shoulder, how can we deliver the posterior? So both are locked. Okay, and especially the first one, the presenting part, which is the anterior one, is locked. So until we deliver that one, we can deliver the later. Are you please okay?
Okay, but it's like you're not getting me. I want to know
Yes,
that
I'm saying
right
that
and
both
left
can lock.
side.
It's locked. Because in normal delivery, you can't have both shoulders coming at the same time. That's not normal delivery. That's not how delivery occurs. The midwives, I hope that's correct. Or
Very true, sir.
Yes, sir, it's
both shoulders cannot present at the same time.
Shoulder presents itself, so you see the shoulder come to tell you that that's the
Yes.
position the child come.
You have to deliver one shoulder first before the other. So once the anterior shoulder is locked, it means that the both are locked. Okay, and mostly the anterior shoulders. So that because the anterior shoulder is presenting first, we are delivering that one first. And once we deliver, we relieve the pressure. The second one coming is just simple. Are you please okay?
yes,
And note here, this is very important. Are you seeing the picture down there? Okay. Let's
Sir, please, your line is breaking.
But Frank, please, your line is breaking.
So the legs are all right. Please, can you hear me now? Can you hear me now, please?
yes, sir.
Hello.
Yes,
Are you okay?
yes.
All right. Can you see that the leg is lifted, and one hand is lifting the leg, okay, and then pointing towards the abdomen, and the other hand is exerting a pressure where?
Over the umbilical area.
Where is the pressure being exerted?
At the same face.
So probably the
lower abdomen.
The lower part of the abdomen. Okay, not the fundus, because we want to relieve the anterior pressure. So that's where the anterior shoulder is locked. So once you point the thighs towards the abdomen, then you exert pressure on the symphysis pubis just to push the shoulder downwards. Okay, so that's how it is done. So with McRoberts maneuver, we don't exert pressure on the fundus. Rather, should be on the symphysis. I please, okay.
Yes.
Okay. So it says that grabs the maternal leg and sharply flexes. You flex the thigh back against the abdomen. Mark cephalad or rotation of the symphysis pubis, flattening of the sacrum. So the sacrum, it will flat the sacrum and removing the promontory or as an obstruction site. The aim is to reduce both the lumbosacral angle and the angle of pelvic inclination. So we just want to reduce the angle. All right, so that the shoulders can be delivered. I please, okay. All right. So that's basically what is termed as McRoberts maneuver. So in McRoberts maneuver, we use it for shoulder dystocia. Okay. So this one, do you think lying, assuming what's the name? Assuming Trendelenburg position or knee chest position, can it help?
Yes.
Can it help?
Trendelenburg can help.
Sir, please come again. What is the question?
Promote the fetal descent, so it cannot help.
I was saying that, okay, assuming Trendelenburg position or knee chest, is it going to help?
No, I don't see how it will help.
Okay.
Because it's
So,
locked in there, right? The shoulder is
yes.
locked.
So the shoulder is locked. Want to relieve it. And just going back or assuming knee chest position, we just push the child backwards a little. But that's not going to relieve the pressure. Okay. So the main thing is to use McRoberts maneuver. So that's the priority. You place the patient in that side and then you do McRoberts maneuver. So priority, you flex the mother's thighs towards the abdomen to widen the pelvis. We stop pushing. We stop oxytocin. Anything pushing, we stop in shoulder dystocia. We stop in what's the name? The one that we talked about first. What is it? Quad prolapse.
Quad prolapse.
So that's what we have to know. We don't want to initiate pushing. Apply suprapubic pressure. The pressure is suprapubic, not fundal. Press downwards just above the pubic bone to help dislodge the shoulder. So applying suprapubic pressure will help dislodge the what? The shoulder, the anterior shoulder. We never apply fundal pressure. Don't go and apply fundal. Don't go and put your hand on the fundus because it's the same thing as pushing. You're not going to do anything. You just want to relieve the anterior shoulder, and that is done by exerting pressure on the suprapubic. All right. We assess the heart rate because we are having fetal distress. The same thing we are having maternal distress. So assess the heart rate. Monitor for fetal distress. we give fluids. The mother is exhausted with what? Prolonged labor. All right. So instruct the client in breathing technique. As someone said, okay, you don't want what? Avoid pushing. So breathing technique will help you. And once you do that, we monitor for color of amniotic fluid. What do you think is important here?
To indicate fetal distress.
It indicates what?
Fetal
Fetal
distress, maybe the
Yes,
presence of
because
material.
very good.
It
Once
told
the
him
fetus,
stain like
yes, once the fetus is in distress, obviously it is going to poo-poo. And when you assess the amniotic fluid, what color are you going to see?
Green, dark green,
Yes.
if
So
there's
once you see that
meconium.
it's greenish, okay, once you see that it's greenish, that means it indicates what? Fetal distress. All right. So that is what you should know when it comes to cord, shoulder dystocia. What
So
are
please, I want
symptoms?
to. So please, I
Yes,
want to
please.
ask that is this Mark Roberts maneuver, is it always 100% successful?
Is it one of what?
Is it always a success
Mark
in
Roberts
shoulder
maneuver?
dystocia? Mm-hmm.
Yes. So that's the best way to deliver the anterior shoulder if the mother is having shoulder dystocia. One of the best ways. So that's why it's our priority. Okay. Our priority here is to get the anterior shoulder delivered. So the best way is to do place the mother in that position. Okay. So that's one of the best.
But Frank,
Yes,
the,
please.
the other material you displayed, I saw some 42% success rate or what? Is it not? Or
Yes, that's why I'm saying that if you want to do all the positions, the best one is Mark-Robert maneuver. You understand?
okay.
The best one to deliver when the mother is having shoulder dystocia, okay, is to have the mother to use what we call Mark Roberts maneuver. That's the best way. That's your priority. That's why NCLEX focus on that, and even in our ward, okay, we focus on that. Okay, so in shoulder dystocia, please know that we focus on using what Mark Robert what maneuver. Are you please okay?
Yes, sir.
So that's what you should know. Mark Roberts maneuver is the best way to go. So if there are positions for you to choose from, the best position that is used in management of this thing is to do the best way of delivering, okay, is to use what? Mark Roberts maneuver. Okay, so that's what we should do. And as I said, we don't leave the patient to first line, Mark Roberts. Quickly place the maternal thigh towards the abdomen, as I said. Okay, and once you do that, it will open space for it widen the pelvis. Okay, so that's what you should do. The last result you can maybe do is do what's the name? The one that we cut the perineum is what? Episiotomy.
Episiotomy.
Mm-hmm. Okay. You do the episiotomy. Okay. Or maybe you have to go and push the head back and do CS. Mm. So if you're not lucky, that's the last resort, to go and push the head back and do what's the name? CS. So that's why this one is emergency. You quickly do a Roberts maneuver. Okay. Once you do Roberts maneuver, it's going to relieve the shoulders. And if we know that the shoulders are not being delivered with this thing, we can also do episiotomy. And if episiotomy is not working, the last thing that you can do is to do CS. Are you okay?
Yes, sir.
Okay. Any question?
Boss Frank.
Yes, please.
Yeah, please. I said after all this intervention and the CS is the last resource, won't there be any complications
For
after
complications,
all this suffering? Yeah.
for complications, no doubt. Sometimes you deliver the baby and you're going to even see APGAR score to be down, because the baby is already experiencing distress. Once it happens like that, then you see the monitor having the fetus having decelerations. Okay, the fetus having, once you see accelerations, sustained one, you can see that the fetus is already in distress, and this thing can come with a lot of complications. And one of the complications, as I was about to talk, is brachial plexus injury. And another name is what? Another name is what?
Shoulder.
Ma delight as well. Okay. Shoulder. Another name is what? Hello.
F palsy.
F palsy.
Okay. Okay. So that's what you should know. Okay. That's what you should know.
Okay, sir. Thank you.
All right. So in this case, brachial plexus injury. You're looking at the brachial plexus. Look at this step. Homecoming. Okay. I hope you can see it. Can you see it?
Yes, please.
Yes. So that is the brachial plexus. Because this anterior shoulder is locked, and with repeated contraction, it will force the anterior shoulder to come. And there can be pressure and injury to the brachial plexus. Okay. And that is a nerve. It's a nerve. We are looking at brachial plexus is a nerve. Okay. And that's what we call Erb's palsy. So Erb's palsy, one of the causes is what? Shoulder dystocia or brachial plexus injury. Know that it's a nerve issue. It's a nerve problem. Okay, it's a nerve problem. And I think, let me show you the baby. Okay. You see it? So there's brachial plexus injury, you see that there's a tear on the plexus. Okay. So that's the nerve between the neck and the shoulders. And look at how the hands has been positioned. Look at how it is. Okay, we are going to talk about it shortly. So that is brachial plexus injury. All right. So back to this, you can see that with Erb's palsy, we are looking at C6C5 injury. And with present with adduction. What is adduction? Adduction is what? Adduction.
Arm
Something moving
towards
internally.
the body.
Yes.
Oh.
Okay. That is it. Internal. So the child can raise or extend the arm, the affected arm. Always that arm is close to the body. That's it's adding up. It's adding up to the body. That's adduction. Abduction is the opposite. So adduction is adding up. So it adds up to the body. Always the hand is on the body. Okay. Internally rotated. As you saw the chart. Okay. Where is it? If you see this one, I have one of the things that I wanted to show you. Then what I wanted to show you is, I'm not seeing it here. Okay, let me type this way. F passing. Yes. Very good. How we can see it? Can you see the picture?
Yes, sir.
You see that forward rotation, rotated shoulders. The shoulder is rotated forward. It's pointing toward the body. It's just adding up to the body. Unlike a normal human being, you can see that on the shoulders, it's just straight, pointing laterally. Okay, pointing laterally. But this one is pointing toward the body. It's rotated. That's forward rotation. It's rotated to in front of the patient. Okay, that's rotated shoulder. And the upper arm is red. Okay, that's blood bleeding under the skin. Muscle atrophy. If the hand is not moving, it's like someone having stroke. Okay, if the hand is just like that, it's not moving, it's not working, it begins to grow smaller. Okay, that's muscle atrophy. Okay, the muscle is thinning and what diminished arm length. You can compare the arms. Okay, the other one is because of the rotation, internal rotation, which is rotated forward. The good one will be longer than the bad one. Okay, and look at the tip. We call it waiter tip position. Waiter tip position. And if you sometimes you want to assess, you grasp the hand, the child or the baby cannot perform proper grasps. Okay, that is what happens here. All right, that is what we call Erb's palsy or shoulder and brachial plexus injury. And you see the eyes. Okay. That's the Horner syndrome. Drooping. The eyelid, that is ptosis. Okay. And smaller people. And see the back, the shoulders. All right. You see, so the one that is raised is the one that has having problem and is internally rotated like a bird. Okay, so that's what is occurring with what? Shoulder dystocia. In this as a complication, that is brachial plexus injury. Okay, so let's finish with the complication and close. We have clavicular fracture. The clavicle can have an injury. So when we have clavicular fracture, what are you going to see? We have what we call crepitus. Like when you move the hand up and down, you see a sound. Okay? You see a sound, producing sound, because once it's broken, when you raise it, you see you hear a sound. Okay? You're going to hear a sound. That is what we call crepitus. Okay? Crepitus, there's also, especially of because we are looking at the hand, so humerus fracture. Okay? So when you see crepitus, it means that there's what? There's a problem. There is a fracture. Hypoxia, because there's distress. Okay, postpartum hemorrhage. And one of the causes of PPH is what? Prolonged labor. And shoulder dystocia is one of the causes of prolonged labor. And because the uterus will be contracting. At the end of the day, it becomes very tired. After delivery, the uterus becomes very tired, feeling lazy to what? Contract. And that will lead to what? PPH. So one of the commonest causes of PPH is prolonged labor. And uterine atony. How are you going to see that the uterus is having poor tone? Atony means what? Absence of tone. All right. So that we are going to see what? Budgy, soft fundus. Once you palpate the fundus, it's budgy, it's soft. Okay. And it's high, it's not involuting. I hope you understand involution.
Yes, sir.
And if it's not as high, we call it what? If it's high and not involuting, we call it
Inversion.
what? We call it what?
Uterine
Inversion.
atony.
No.
Sub-involution.
Yes, the word again is what?
Sub-involution.
Sub-involution. Okay, it's not involuting. It's not going back to pre-pregnancy state. All right. So once you assess the uterus and then some days it's not going back after delivery, you see the fundus is still high. Okay, it's not going down. That is some involution, and that will cause bleeding. So once fundus is soft, it's high, it can cause bleeding, and you see that there's going to. So that will be signs of uterine atony. So signs of uterine atony, the signs of uterine atony, the uterus not having any tone, not contracting well, it will be body soft, okay, very high, not going down, and there will be bleeding because any cause of atony will result in bleeding. Okay, so what do? Once we see that, we do what? Do fundal massage. Quickly, that's your priority. Massage the uterus. If you assess and then you see that it is a sign of uterine atony, please, your first action is to massage. Okay, you empty the bladder because full bladder can also cause what? Uterine atony. All right, the uterus is not contracting. Maybe the cause is, or sometimes you can see uterine deviation. Okay, the uterus is not as shifted because once the bladder is full, it will push the uterus to the other side. So you see that asymmetrical uterus. It will be a sign that the uterus is the bladder is what? Full. Okay. We do bimanual uterine compression. What is bimanual uterine compression? Yes. It's Debbie.
Compressing the uterus on both sides.
On both sides?
Manually.
Okay. Thank you. Yes, any other? Bimanual uterine compression. Yes. Bimanual. Hello? What is it? Midwives, where are we? Okay. When you talk of bimanual uterine compression, please take note of this. Okay. This one, when especially we are dealing with what? Uterine atony, where there's vaginal bleeding, where there is ongoing PPH. We can also use bimanual uterine compression to control bleeding. Are you please? Okay. So this one is just a technique. You are compressing the uterus. So know that in this one, it's not your hand at the both sides of the uterus. No. One hand is inside the vagina. Are you here? One hand is what? Inside the vagina. All right. That one is supporting the uterus. And the other hand will be on the abdomen. That will press down the abdomen. Okay. Where the fundus is. So you do that. Once you are compressing, all right, you are elevating the uterus, like you are elevating the uterus by inserting your gloved hand, sterile glove hand inside the vagina, and the other hand is on the fundus. That's what we call bimanual, because we are using both hands, one inside the vagina, or one inside and one outside the fundus. And you're compressing. This one helps in controlling bleeding. Are you please okay?
Yes, sir.
So that's what is called bimanual uterine compression. And we use it when the uterus is bulging. First of all, know what is causing. Is it the bladder which is full? Okay. Assess your fundus. Is it bulgy? Is it soft? Okay. And finally, you can use what we call uterine balloon tamponing. Balloon tamponing. I hope. How is it done? What is it?
It's like a catheter is placed inside the uterus through the vagina and inflated to exert pressure on the uterine wall.
Okay. That is uterine balloon. Like a balloon, you inflate it. Okay. And compress. Tamponade means that compression. It's like cardiac tamponade. Okay. Fluid surrounding the heart, compressing the heart. Okay. So this one is balloon inside the uterus, inflated balloon. Okay. Compressing the walls of the uterus so that any blood vessel which is exposed will what? Constrict it and prevent bleeding. Okay. So these are causes of complications of shoulder dystocia. You're going to have an injury to the either the nerve or the bone. On the nerve, we call it brachial plexus injury. On the bone, we call it clavicular fracture. All right, where you are going to see crepitus as a major or hallmark sign of fracture. Crepitus. Right, hypoxia because of distress, bleeding because of prolonged labor. All right, and uterine atony, be tired after delivery. So that is it. Thank you. Any question? Any question? Any submission? All
Yeah,
right.
hello, sir. So, a
Yes.
question. You
Okay.
spoke about the brachial plexus injury.
Mm-hmm.
So, is it a lifetime condition? Can it be corrected as a child grows?
This one, when we have brachial plexus injury, it's very difficult to to correct that one. Okay, very very difficult because over here we are looking at the nerve. Okay, when we have the what's the name, the nerve, an injury to the nerve. Okay, once there's an injury to the nerve, it becomes very difficult to repair. But notwithstanding, we can have other ways of correcting that, and that is mostly through exercise. Okay, to do exercise, so we have to refer the patient to uh, the physiotherapist. Okay, just to do
Okay.
exercise.
Exercise.
I please okay. So
Okay, sir.
mostly one of the ways of treating this condition, but we early treatment is the best. When the child is having an injury, you start exercise as early as possible. Exercise, exercise. You have to sometimes you have to place something in the hand for the child to be for the child to grasp. Sometimes you have to
Okay.
be raising the hand because we are going. If not, you see what we call atrophy, muscle atrophy. That's the muscle what thinning, becoming smaller, smaller, smaller. It's not growing. It's like a patient with stroke. If the hand is not being exercised, it ends up thinning. Okay. So that's mostly what they do. Exercise is the best. Okay.
Okay, sir. Thank you.
All right. Are you okay?
Yes, I'm fine. Thank you.
All right. Okay. If there's no question, then no. But one thing is, please don't confuse the management of shoulder dystocia. Okay. Especially know that your position when it comes to shoulder dystocia. No position that will help. So when the question is dropped, don't go and choose any other position that will not help with the management, relieving the pressure. That should be your focus. This position is it going to relieve the pressure? All right. So that is what you should know. Okay. Thank you so much for your time. God willing, tomorrow we are going to meet and we will talk about this. Have you seen this? Anaphylactoid. Okay. Syndrome of pregnancy. And that is, we call it amniotic fluid embolism. That's a previous name. Okay. So go and learn about it. Tomorrow, God willing, we meet. Thank you so much.
Thank you, sir. Thank you, everyone.
All right. So when you talk of anaphylactoid syndrome of pregnancy, please take it. It's the same as amniotic fluid embolism. All right. And when we talk of embolism, I hope which organ is most affected or most serious when you think of embolism? Lungs. Very good, lungs. So when we are thinking of anaphylactoid syndrome of pregnancy, look at the word anaphylactoid. Means that it's going to produce anaphylaxis. Okay? It's going to produce anaphylaxis. So once you know that it's going to produce anaphylaxis, then you have to know the signs and symptoms that come up with it. Okay. So that was the initial name, an amniotic fluid embolism. It's the escape of what? Amniotic fluid. So once amniotic fluid finds its way into maternal circulation, and you know, the fluid and the blood, they are different. Amniotic fluid and the blood, the components are different. So when it's find its way into maternal circulation, it will form an embolus, like a clot. Okay. And once the mother moves, once the mother is exercising, this embolus will gradually find its way into the lungs. All right. So basically, that is what is happening here in anaphylactoid syndrome of pregnancy. So this debris that contain amniotic fluid will deposit into what? Into the pulmonary arterioles. That's the small arteries. All right. And once it's deposited, it will cause an anaphylactic-like reaction. All right. That's why they've changed the name from amniotic fluid embolism to anaphylactoid syndrome. It means that it's going to produce anaphylaxis. Okay. So, and once it produces anaphylaxis, you know, anaphylaxis is fatal. It's usually fatal. All right. So, when will it occur? During labor, during delivery, placenta accreta spectrum. When I say placenta accreta spectrum, what does it mean? Yes. Hello. Let's talk.
The placenta enters into the middle lining of the uterus, very deep inside. It attaches itself deep.
All right. So placenta accreta. This placenta is embedded deeply into the muscles or into the uterine wall. Okay, that's what we call. So once it embeds deeply, okay, and if it happens like that, you know, it predisposes the mother to get out an anaphylactoid syndrome of pregnancy. And when there's rupture, uterine rupture, because obviously there's going to be rupture of the amniotic fluid, okay, trauma or surgical procedure, okay. And when you also have history of allergy, you already have history of allergy. And once this one gets into the arterioles and it starts producing the anaphylaxis, obviously once you have history of allergies, it will predispose you to this condition. All right. What are you going to see? Know that this is a sudden issue. It's like pulmonary embolism. They're all sudden. Okay. And once it happens like that, it's going to drop the oxygen. And it says thing drop in oxygenation and bleeding. Okay, bleeding will occur. And acute respiratory distress causing the lungs. So obviously, it's going to produce cyanosis. Hypotension will come because with anaphylaxis, that's the two things, lungs and what? With anaphylaxis, what organs are mostly affected?
The airway.
And the what? The heart.
The lungs.
The lungs, heart, and the brain. The heart, lungs, and the brain. When you talk of anaphylaxis. All right. So with this, it's going to affect because a lot of inflammatory chemicals are released. Okay, markers, they are released. And this is going to cause massive vasodilation and eventually leads to hypotension. Okay, and the cardiovascular system will eventually collapse. And once there's vasodilation and there's hypoxia, okay, this thing will cause the brain to have altered mental states. All right, and that one will lead to seizures. Okay, so that is what you should know. Because of shock, shock will lead to altered mental states. Hypoxia too, when there's low levels of oxygen, they will cause altered mental states. Okay, and eventually the patient will develop seizures. So know that in this scenario or in this condition, patient will develop seizures. Not only in eclampsia or in eclamptic patients. This will lead to seizures in anaphylactic syndrome of pregnancy, anaphylaxis. Okay. And there's going to be disseminated intravascular coagulation, DIC. Okay. And in DIC, you have two major problems, bleeding and clotting. Bleeding and clotting. So there's bleeding from multiple sides. It all has to do with this fluid. All right. This fluid led to all this cascade. Okay. So there's going to be widespread clotting. Okay. And once clotting is ongoing, know that platelets forms the clot. So eventually, these clotting factors will eventually what? Reduce. Okay. Because these clotting factors are forming clots. So if you do your labs, you're going to see that there's going to be depletion of clotting factors. Are you please okay? And eventually cardiac arrest. So look at the lungs, look at the heart, as well as the brain. These three areas will be massively affected with anaphylactic syndrome of pregnancy. Are you okay, please?
Yes.
Please, I have a question.
All right.
I understand everything you have said, but I don't understand how the bleeding will come in.
How?
The bleeding will come in.
Okay. So one thing is that when there's when there's amniotic fluid, when this amniotic fluid finds its way into the maternal circulation, okay, it undergoes through a lot of processes. Okay, one thing that you should know is that when we have this amniotic fluid, when they are circulating in the blood, okay, these tiny clots, once it develops in the lungs, or if there's developing of this thing, the clots in the maternal circulation, okay, know that the whole thing will result from the amniotic fluid entering the maternal circulation. All right. And this amniotic fluid, it contains this, the part of the fetal cells. Okay. It contains, what's the name? Thromboplastin. Okay. It contains a lot of things, fetal debris and whole lot. Are you please okay? And
Yes, please.
because of these content or components, okay, these components, there's going to be a tissue, what we call tissue factor. Okay, And this tissue factor, once there's this component in the blood, this tissue factor is going to what? Trigger clotting. It's like when we were doing, those who were in the discussion page, when we were doing this thing, what's the name? Cardiac catheterization. Okay. When we think of atherosclerotic plaque, once it breaks off, I told you that clotting factors or platelets will engulf around the plaque that has been ruptured. Okay, it's the same thing. Once there's foreign body, which is the amniotic fluid, in the maternal circulation, that is going to trigger clotting. Are you okay, please?
Yes, please, I understand.
That one would trigger clotting. Okay, and once
So it
clotting,
means it means that before the bleeding, there will be clotting, as a way of the body or the mother's body trying to engulf the supposed allergic causing so the amniotic fluid in the blood, and because there will be clotting, it will deplete the ability of the body to have clotting factors to stop bleeding, and subsequently to lead into bleeding, right?
yes, please.
Thank you.
All right. Can you please move on? All right.
Yes, boss.
All right, thank you. So once we have, and note that mostly all foreign material that finds its way in the blood, most of them produce bleeding or DIC. For example, when we have preeclampsia, with preeclampsia, you know that the whole problem has to do with the placenta. Okay, when the placenta tissues start stops detaching itself from the wall, some of the debris or particles find its way into the maternal bloodstream. Okay, and sometimes these particles they're going to be activation of clots, because sometimes too it can be that the blood vessel itself that is supplying the placenta is having issues. When there's necrosis coming, okay, these clotting factors will be activated and eventually leads to DIC. So most of the times, most of foreign materials that finds its way into the bloodstream mostly leads to bleeding or DIC. Are you okay, please? Mostly leads to DIC. Okay, so that's what you should know. So once amniotic fluid is a foreign material that finds its way into the maternal this thing, it can lead to DIC. Someone is saying, what is the topic for headache? We are doing anaphylactoid syndrome of pregnancy. Okay, that is amniotic fluid embolism. Okay. All right. So that is basically that. Do you understand, please?
Yes, please.
Okay. So if there's ongoing bleeding, ongoing clotting, okay, there's anaphylaxis, which is ongoing. You know that fibrinogen, okay, is part of materials that are used to form the clots. Okay, so if there's ongoing DIC, in DIC, the point is that the materials that are being used to form clots, like platelets, Okay, like fibrinogen, that one forms the mesh. It's like when the first thing is that platelets will form at the beginning. And this fibrinogen, okay, later into fibrin, will form around the formed platelets to make it firm. I hope you understand. They will form a mesh around the platelets so that the clot will be firm and be able to move around. Okay, so know that fibrinogen and platelets are used in what? Forming clots. And once they are used in forming clots, the levels will eventually go down. Do you understand, please?
Yes.
Are you okay? Okay.
Yes, please.
And PT. What's the full meaning of PT?
Prothrombin.
Okay. Time. And we are looking at, it's like the time it takes for the blood to clot. And the one that is standard, we have different distance. Every lab has its own value. But because we wanted a national one, that's why they come up with a INR. Okay, so that's the standardized form of the PT. So this thromboplastin time will what? Increase. The time it takes for the blood to clot will what? Increase because there's ongoing bleeding. Do you understand, please? Because all the platelets are being used, fibrinogen are being used, so it takes a long time for the blood to clot. Hence, an increase in PT. Okay? Activated partial thromboplastin time, that one too. Okay? They will activate it, and then that one too will also increase. D-dimer. D-dimer will tell you that there's ongoing clotting.
Yeah.
Okay? That's the main function, D-dimer. So when they do D-dimer, it tells that there's ongoing clotting. That's why in COVID, they were using D-dimer. Because in COVID, there was clotting issues. So D-dimer will tell that there's ongoing clotting, but we don't know where the clot is. So D-dimer will not, what's the name? Will not confirm the diagnosis. It's other lab works that they do, but it wouldn't confirm the diagnosis itself, but it will confirm that there's ongoing clotting. All right. And that one will also lead to metabolic acidosis. Why metabolic acidosis? Why metabolic acidosis, please? Yes.
There may be formation of clots in the blood vessels in the kidneys. So there will be decreased perfusion, which will make the kidneys to retain more potassium and unable to increase excrete them. And the poor perfusion.
Any other? Thank you, Mr. Frank.
For this case, okay, I want to try. Because of the bleeding, it has caused the pH level to drop. So that's why you have that metabolic acidosis.
Is that it cause what?
And so that's why you get metabolic acidosis because the pH level has dropped.
The pH. Okay. All right. Thank you. Any other? Lisa Jane, you want to try?
Listen.
No.
Listen. Oh,
Yes.
sorry. I was thinking that if there is bleeding, there is poor perfusion to the kidneys and other organs, so that will lead to the metabolic acidosis.
All right. Thank you so much. You all did well. One thing that you should know is that this one leads to what is called shock. Shock. And shock, there's what? Hypotension, tachycardia. And in shock, there's decreased tissue perfusion of what? Oxygen.
Oxygen.
So at the end of the day, the tissues will lack oxygen. And what will they use to produce energy? What will they use? The carbon dioxide. And eventually leading to what? Lactic acidosis. And then metabolic acidosis. So in shock, not only in this, in shock itself, or in sepsis, because sepsis also leads to shock. In shock, in sepsis, in anaphylactic syndrome of pregnancy, there is shock. And in shock, there is metabolic acidosis. Please take note. In shock, there is metabolic acidosis because tissues are not getting oxygen. They rely on carbon dioxide to produce energy, eventually lactic acid. And once lactic acid accumulates in the blood, it will decrease the pH. Are we together?
Yeah.
Thank you. Then there's hypoxemia. Okay, there's hypoxemia because these clots, anaphylactoid syndrome of pregnancy, that is the embolus. They are in the what? Arterioles, in the lungs. So they would oxygen perfusion to the tissues will eventually decrease. Okay, in the blood as well. Okay, so perfusion, ventilation perfusion mismatch. All right, and that will cause hypoxemia. All right. What are we going to do? That's the nursing intervention. And know that if you understand this condition, there is shock, there is respiratory issues, that's cardiac issues, respiratory issue, as well as what? Brain. These three areas, whenever there is shock, whenever there is anaphylaxis, that's why in anaphylaxis, we do give what? When we want to open the lungs, that's why in anaphylaxis, we do give EpiPen. I hope you know, epinephrine injection to just open the lungs because there's vasodilation, there's bronchoconstriction. That's what is happening here. In anaphylaxis, there's vasodilation leading to hypotension, and there is bronchoconstriction in the lungs, constriction, patient having difficulty breathing, oxygen in the blood decreasing, and leading to hypoxemia, hypoxia. Are you okay? So once there is, you have to activate what? Rapid response team or initiate cardiopulmonary resuscitation. Mind you, we are doing maternal emergencies. And anaphylactoid syndrome of pregnancy is one of the maternal emergencies. So in this case, Mr. Dorothy, please. In this case, you have to initiate what? CPR if there is cardiac arrest, because the anaphylaxis will lead to cardiac arrest eventually. All right. So the mother is pregnant. In CPR, how do we position pregnant women to do CPR? Okay. or if there's mother is in labor and you are doing CPR, what do? Tilt the client 30 degrees to the left to displace the uterus to prevent vena cava compression. Are we here? It's like you are placing it, the mother is in left lateral, left. Okay, but we tilt the client 30 degrees. Like you place it in left lateral, but not in a complete left lateral position. Okay, you don't place the mother who is pregnant in supine position to do CPR. Are we together?
Yes, sir.
All right. So once the baby is inside in utero, please tilt the bed to the left side, left. All right. You want to displace the uterus in order not to compress the inferior vena cava. And if there's shock, obviously, or in this issue, because of respiratory compromise, we are going to give what? Oxygen.
Mhm.
Okay, so we give oxygen in this case. All right, that's what you should know. And apart from that, we prepare for intubation. Anaphylaxis, we prepare for intubation. And also prepare for emergency CS because there's respiratory compromise. And the baby too will be compromised. So you have to prepare for CS. Okay, so that is what you have to know. So before that, you prepare for intubation and prepare for CS. All right, and prepare for emergency delivery to improve maternal fetal survival when client is stabilized. Okay, so once the client is stabilized, like after intubation, after resuscitating, the client is stabilized, then you quickly deliver. Okay, the mother will need fluid because there's hypotension, blood products, because there is what? DIC. Okay, medication. What are you going to give? Vasopressors. Vasopressors going to press the vessels up.
Okay.
Okay, an example is what? Vasopressors.
The smoke press.
Pardon?
You have the smoke pressing.
The smoke pressor. Okay. Any other? Have you not been using noradrenaline, dopamine, dobutamine? I hope you've been using them at the what? Hello?
Yeah. No
Yes.
epinephrine.
That is they are vasopressors. Okay, they are vasopressors. So just take note of that. So we have to give these dobutamine. Okay. What's the name? Noradrenaline. Okay, just to press the vessels. All right. That's to increase blood pressure because of shock. All right. And we have to also monitor for the fetus, the heart rate. Fetal monitoring is very, very important. Okay. And we treat DIC with blood products like what? Platelets and frozen plasma.
Fresh frozen.
Yes. Okay. Let me ask you. Do we give heparin in DIC?
Yes, sir.
Yes.
Yes, we give.
When are we supposed to?
Boss Frank, please, do we give what? Sorry, I couldn't hear that part.
All right. I said heparin.
Okay, it's not used in pregnancy. Oh, I don't
Heparin.
know.
Even if bleeding,
They give
if
adrenaline. I mean,
Yes.
Exacina.
Please talk to me.
No, we do give.
We do give. I'm saying when.
we give heparin if the problem is clotting.
If the
Like
problem is clotting. Yes.
Yes, if the
Obviously, there's clotting. In DIC, there's clotting. There's bleeding as well. Right?
during CS, during when they are performing the cesarean session, they pass heparin in their infusion.
No, they give before the CS.
They give what?
Before the CS.
Before the CS.
Like some hours before.
Okay. All right. Any other?
is it the same as in how is it called, dialysis or what?
That dialysis. Are you
Because
talking
I
of
came
heparin?
across some, yeah, or
Heparin. The drug. What class is heparin?
it's an anticoagulant.
Mm-hmm.
I think you give heparin when bleeding is the main cause of the DIC.
When the main cause of what?
Me, for what
I
I
didn't
know,
hear you.
then when bleeding,
Okay.
you say DIC.
Mm-hmm.
But was fine. Heparin in DIs, I think you should give with carefulness.
That's why I'm asking, when do we give? When?
When the
When the clotting
operating,
is very massive.
When the what?
Yes.
The clotting is very massive.
Yes.
Mm-hmm.
when they
So
operate after the operation, one of the medication that will pass
I think
after
it's
they
not
do.
given in all cases, except when there's massive clotting, like she said.
what I'm talking about is not after delivery. I'm looking at when there's amniotic fluid embolism, while the woman is still pregnant.
Okay.
Okay. And
Okay,
when do
okay,
we
but
give? Yes, please.
okay. Yeah, I think heparin should not be used in this case because although the patient is clotting, but the patient is also bleeding at once. The
Sister
heparin is
Abigail,
also,
please, you are right on our screen.
so I think the heparin is going to cause further bleeding.
In DIC, right?
No, in this case,
How is it going to cause further bleeding?
I would like to also come in here. I don't know.
Okay.
I believe that heparin should be given only if maybe the patient is suffering from chronic DIC or with excessive clotting.
Okay.
Right? Because if maybe the patient is bleeding too much and you give a heparin, maybe probably you are going to worsen things. But then if it is like chronic thing, that is where I think you can use heparin.
Okay. So the whole thing is that we give when there's massive clotting ongoing. Okay. Because once there is bleeding, so even not in anaphylactic syndrome of pregnancy, if it has to do with DIC, okay, please note, or maybe HELP syndrome, okay, or preeclampsia, which of course leads to DIC. Please note, we only give heparin if there's ongoing massive clotting. So that's why you are expected to read your labs. You understand? So if the platelet is too low, and in the case scenario, they are saying that there's ongoing bleeding, you are not expected to give heparin. Are you okay, please?
Please repeat that.
Please. Pardon?
Please repeat the last statement you made.
How do I even remember the last statement? I was saying that if, let's say, the woman is having DIC, which of course can result not only in anaphylactic syndrome of pregnancy, in preeclampsia, in HEP syndrome, if there's DIC, okay. Obviously, we give heparin, but ask yourself, when you check your labs, before you give heparin, check your labs. Is there ongoing bleeding? How are you going to see? Look at your lab. Look at your platelets. Look at your PT.
Your D dimer.
Your D dimer. Because they are going to give you what the lab work, and they are going to give you the expected the range. So look at all these things. And if you know that your PT is way high, okay, let's assume the broad INR and it's very high, above the upper limit. You are not going to give heparin because there's ongoing bleeding, which of course the labs have confirmed. Do you please understand? So once there's ongoing bleeding, based on your lab's work, based on your symptoms, presentation, please hold on with heparin. And it doesn't become something that is unnecessary. In this case, it becomes what? Contraindicated. Become contraindicated because once you know that bleeding, there's ongoing bleeding. If you give this, contraindicated means that something when you give it, it's going to result in danger. If it's not necessary, means that whether you do or not, it's not going to lead to anything. But contraindicated means that there's danger when you do it.
Okay.
Are you okay?
Yes. When the lab there is active bleeding, you don't try heparin at all. But then you can give heparin when there is. I said when the labs show that there is active bleeding, then you don't try heparin at all. It becomes contraindicated. But you can give heparin in the situation whereby there is active clotting and your lab work shows that there is no sign of bleeding with the patient, right?
Exactly.
Thank you.
No. Are you okay?
Yes, please.
Okay. All right.
So, Boss Frank, please, I have a question.
Okay.
So, please, in DIC, is it possible to have only clotting without bleeding?
DIC, clotting without bleeding.
Yes.
DIC itself is clotting and bleeding. It's a cascade. It's a process. A cascade. Okay. So it's not possible to have one without the other.
Okay, thank
you. Okay. Let me ask you, can this thing lead to heart failure? Yes. Hello.
It can lead to heart failure.
Yes.
Ah, okay. Can someone explain how?
Okay, please let me try. So
Mm.
this is a situation where there is active clotting. It means that the flow of blood is going to be impeded. Otherwise, there will be active bleeding, which means that there will be less fluid volume in the blood vessels. Given that, it means that the heart, aside the blood going to the heart being inadequate, the heart muscles will also not get enough blood to pump blood into the system, which will lead to shock.
Okay.
And if nothing is done with the shock, all these vital organs, the brain, the heart muscles, and even the lungs, because there's less gaseous exchange with the active bleeding and even with the clotting, because the clotted blood wouldn't be able to carry oxygenated blood to the cells. It can finally lead to cardiac arrest or, yes, heart failure because of this cascade of events happening. That's my
All right.
take, though.
Thank you. Any other?
Okay, boss Frank, I also want to try.
Mhm.
We said that with DIC there is bleeding and clotting. So the profuse bleeding can also result in poor perfusion or no perfusion at all. And when there is no perfusion, organs will begin to fail, which can lead to the heart being failing as well.
Okay. All right. So eventually there's going to be heart failure because know that there is, as I told you, there's vasoconstriction. Sorry, there's bronchoconstriction. Okay, because of anaphylaxis, and there's clot there. Sorry, embolus. That's fluid embolus. Okay, and that will increase what's the name? Pulmonary hypertension. And you know, the right side of the heart pumps blood to where? The lungs. Okay. So if there is clots elsewhere and it's not allowing blood to flow easily, it means that there's going to be pressure on the right side and eventually leads to the left side pressure, which leads to left ventricular failure. So we are going to have right-sided heart failure, left-sided heart failure in anaphylactic syndrome of pregnancy. Do you please understand? Are you okay? All right.
Yes,
Yes,
boss.
So
please.
that is what you should know. So in this case scenario, know that your first thing that you are going to see is in the lungs. Is in the lungs. You are going to see those lungs symptoms. Sudden drops of what's the oxygenation, okay, chest pain, because there's oxygen issue, and every oxygen issue leads to pain. Chest pain there, the patient will be anxious, not knowing what to do. It's like having pulmonary embolism, okay, like something impending doom. All right, and cyanosis and leading to this cardiac symptoms as well as um, brain symptoms. All right, so that is what we should know. So always know your respiratory as your priority. High place, okay. And because there's going to be fluid accumulating in the lungs, sometimes lead to crackles in the lungs, tachypnea, those stuff. All right. So that is what you have to do. And once there's going to be hypotension, your pulse, how will be the pulse? How is the pulse? How will it be like? Pedal pulses. How is it going to be? Yes.
It will be weak and steady.
Yes. Because circulation is bad. Okay. The capillary refill type will have to what? Increase, right? Urine output, what will happen to it? Because there's shock. All these things will come. All right. And if obviously because there's brain involvement, low level of GCS. Okay. So that's what you have to know. And once we are having DIC, when DIC comes in, that's when we are going to have what's the name? Petechiae. Okay, ecchymosis, that's bleeding under the skin. You're going to see all these things. We're going to see that the patient is bleeding from the gum. The patient is bleeding from IV sites. Okay, the patient is having vaginal bleeding. Don't always think that it's PPH. If there's a sudden, if this thing occurs suddenly, respiratory issues suddenly, please think of embolism. Are you please okay? Are you okay? So
Yeah.
in this case,
Yes.
what will happen to your hemoglobin? Because DIC. So what will happen to hemoglobin and hematocrit?
They will decrease.
Yes. So if you want to confirm if there's DIC ongoing, also monitor for your what? Hematocrit and hemoglobin. Because there's ongoing bleeding, which will cause a reduction in the blood. So always, for your labs, dear, please don't lose sight on. Always focus on your labs before you want to confirm if this is the diagnosis or whatever. Confirm your labs. Okay, confirm your labs. All right. So this thing, know that it's obviously anaphylactoid-like symptom that the patient is presenting. But let me ask you, are you going to give EpiPen? Yes.
Yes.
You give EpiPen, right?
Yes.
Okay. Who else?
Yes, you mentioned vasopressors.
Sir, please, question again.
This is, anaphylaxis. In anaphylaxis, we give EpiPen, isn't it?
Yes, please.
As your first line of medication.
Yes, please.
And my question is, in anaphylactic syndrome of pregnancy, do we give EpiPen? Yes. As
Yes,
simple as
please. You can.
ABCD.
You can give. Yes, please. You can give.
We can give.
Yes, please.
Okay.
Provided it's available, you can give and wait for further intervention.
It's always available. In English, everything is available. In the English world, everything is available. Okay. So we can give, but most of the times we deal with the airway. We deal with. That's why sometimes we prepare for what's the name? Intubation. You understand? We prepare for intubation. So with airway issues, but in when we take the NCLEX standard of treatment with regards to amniotic fluid embolism, we don't usually give them. We don't usually give EpiPen. Are you please okay? Are you okay? Because as I said, it is anaphylactoid-like. It's not an actual anaphylaxis where it's going to produce the itching and those stuff. It's not an actual one. It's anaphylactoid-like. Okay, so that's what you should know. So we don't usually give EpiPen. All right. So that's what I want to tell you. All right. Let's move on. Any question?
Yes, please, I have a question.
Okay.
Please, about the EpiPen. In the interventions, you mentioned that we should administer IV fluid, blood products, and medications. And you said vasopressors. I thought epinephrine is a vasopressor.
Mm-hmm. Yes. So
Or it is the route of administration that is the problem.
not the route. EpiPen. Okay. When you give EpiPen, what does it do? When you give EpiPen, what does it do?
Like to treat the emergency.
Is that?
It's like an emergency treatment for anaphylaxis.
Mind you, in
To constrict
anaphylactoid, in when we give EpiPen, because in anaphylaxis, there's vaso what? There's vaso what?
Constriction.
Constriction.
Direction.
Hey,
There is
vasodilation
vasodilation.
and broncho
Constriction.
bronchoconstriction. So you don't forget, because vasodilation will lead to the hypotension, will lead to the shock, and bronchoconstriction will lead to airway compromise, difficulty breathing, tachypnea. Okay, so in this case, when we give EpiPen will cause bronchodilation and vasoconstriction. Sister Safini, please try as much as possible to mute yourself. So there's when we give the EpiPen, okay, it's going to cause bronchodilation. Sister Stephanie. All right. When we give EpiPen, I said it's going to cause what? Bronchodilation, because there's bronchoconstriction. And it's going to cause vaso what? Constriction. It's going to cause the opposite of the condition. All right. But in no epinephrine, it's not going to do as EpiPen does. Okay. Though norepinephrine is a vasopressor. It presses up the vessel. It's a vasopressor, but it doesn't work by causing bronchodilation. Are you please okay?
Yes, please.
Mm-hmm. All right. So that's what we should know when it comes to the management. You have to give vasopressors. Okay. So that's what you should know. Any other question before you move on to uterine rupture? Any question? All right. So please,
Boss Frank.
yes, please.
So it doesn't mean that in AP the anaphylactoid syndrome of pregnancy, if you give anything that will cause vasoconstriction during the process, it's going to affect the mother.
When you give anything that will cause vasoconstriction,
Vasoconstriction, yes.
it's going to affect the mother.
Yes, it's a question I'm asking.
No, it's going to help in treatment. Because in this condition, mind you, it is anaphylactoid-like syndrome. Means that there is vasodilation and bronchoconstriction. So when you give anything that will cause vasoconstriction, you are rather increasing the BP. So when you give anything that will cause vasoconstriction, you are helping the mother, not other way around. Are you okay?
Yes, please.
Mm-hmm. Any other?
So, but Frank, what happens to the baby in all of these things?
When it happens like that, in hypotension, blood flow to the fetus will decrease. Two of us.
True.
True of us.
True.
When it happens like that, what type of deceleration are we getting? Yes.
Late.
Late. So obviously, the fetus is going to experience late decel. That's why, in this case, we monitor the fetal heart rate. The monitor. You have to check because it's going to lead to all these things. Are you okay? So in this case, please don't forget DIC in anaphylactoid syndrome of pregnancy. Don't forget shock. Don't forget respiratory failure. Don't forget seizures as a result of hypoxemia to the brain. So these areas, when there's shock, know the signs. When there's respiratory depression, know the signs. And when there's decreased blood and oxygen flow to the brain, know what is going to happen. As well as DIC in this condition. All right, uterine rupture. That's what we are going to talk about. Uterine rupture. So when we say rupture, it means that this can be a complete or incomplete separation of the uterine tissues. Okay. And once it happens like that, it will lead to bleeding. And when does it, how does it result? As a result of severe stress of labor. When contraction is so much. Okay. All right. I hope you know Taki, what's the name? Tachycystole. You know it, right? The last time I explained to you. All right. So what are some of the risk factors for uterine rupture? When there's previous CS, because once the uterine has been and has undergone CS, there's wound. So if there's contraction, okay, know what is going to happen. And we have what we call TOLAC, that trial of what? Labor after CS. Once you do CS, you have to do trial in your next pregnancy. You have to try whether you can deliver per vaginum. All right. And trial if because there's going to be contraction. And if it happens like that, it can lead to rupture. Okay. Because once there's CS, you know that there has been a cut over the extension of the uterus. That is in multiple pregnancies. Okay. When we have uterine surgery, myomectomy, or there's a trauma, okay, the mother falls or motor vehicle accident, okay, and it happens or it affects the uterus, or when you are using oxytocin, when you are doing induction, overstimulation can cause rupture. That's why you have to monitor the contraction. Once you are giving oxytocin, monitor contraction. And if you've delivered a lot, because pregnancies, more pregnancies, you know that the uterus has now becomes weak. All right. So excessive pressure can cause a rupture. And when we have obstructed labor, okay, prolonged labor, because prolonged labor, there's know that this contraction is a natural process. So as long as the baby is inside there, there's going to be contraction. Okay, and this contraction, and you know that if we are nearing delivery, contraction, the frequency increases, duration lengthens. Okay, and this thing can cause that. And malpresentation, okay, breech, okay, frank presentation, patient, the baby coming with the buttocks, anything, because they're going to cause stress on the uterus. Okay, how are you going to see? When we have rupture, there's rupture. It means that blood flow to the uterus, to the placenta is going to decrease. So obviously, we are going to have what? Non-reassuring fetal tracing. That is late decel. Placenta insufficiency because there's rupture. And bradycardia is expected to happen. Okay. Fetal distress is expected. So once you see that the fetal heart rate is increasing, okay, you see that there is a... Please mute up. Mr. Idrisu. Mr. Idrisu. Mr. Idrisu. Please, a minute. I want to remove some people from the group. Mr. Idrisu. Okay. So, sorry. Okay. Sister Abdul Razak. Sister Abdul Razak, please mute your camera, okay? All right. So let's continue. Where am I? All right. So if there's rupture and you do fundal assessment, are you sure you are going to feel the presence of fetus in the uterus?
No.
No. So when you do palpation, okay, you are going to palpate the fetus outside the uterus. And when it happens like that, there is a complete rupture. All right. And sudden severe pain, abdominal pain, that feel like a ripping or tearing sensation. Sudden pain, because once there's rupture, rigid abdomen, because the content has been released into the abdomen. So abdomen becomes rigid. Chest pain, bleeding, oxygen issue. Everything oxygen leads to pain. Vaginal bleeding may be minimal. Please take notes. Vaginal bleeding may be minimal because there's ongoing bleeding in the what? In the
conceived in the uterus.
yes. Okay. So bleeding, that's why it's add up to this thing, rigid abdomen, because there's ongoing bleeding. Okay, so you see that you are going to have minimal bleeding. And if you want to assess there is uterine rupture, this is the number one sign. Please take that we are going to palpate the fetus outside. So when the question asks you to palpate, assess the fundus for the present, maybe you are going to assess the fundus for present of what? Fetus? Please is no. You won't palpate the fetus in the uterus. So when you palpate, you won't feel anything. All right. That's what you have to know. And the signs of shock, because bleeding. And shock produces what? Hypotension, tachycardia. Okay. And there's going to be cessation of contraction because the uterus itself is ruptured. Okay. So cessation of what? Contraction. Right. That's what is going to result.
Was Frank?
Yes, please.
Please, I have a question. You said the fetus wouldn't be palpated in the uterus. So I understand that the uterus is ruptured. So at this point, where will be the baby? In the abdomen of the mother?
Yes.
With all the amniotic fluid and everything inside the mother like that.
That's why the survival of the baby is not reassured.
Okay.
Are you answered, please?
Yes, please. So I wanted to understand that, okay, so you won't palpate the fetus inside the uterus, but then it will be in the abdomen. So if you are palpating, what are you looking out for? How would you know as a nurse trying to palpate to see if there is uterine rupture for the patient?
All right. Obviously, the woman came to you pregnant, isn't it?
Yes, please.
The woman is pregnant. The woman has confirmed that there's pregnancy. And you are doing ongoing assessment. You want to monitor if there's going to be fetal heart rate. Okay. You want to palpate the fundus to know if maybe to check for where the head and then the back is. Okay. So once you are doing that, you're not going to palpate anything there in the uterus. Why? Because there's rupture and the content has been released into the abdomen. So when you palpate, you won't see anything. But ideally, once the woman is pregnant, you should be able to palpate fetal parts. There should be, what's the name? Fetal part present to palpate for you to know that this is the head, this is the back. Okay, the fetus is presenting with the head or whatever. All right. If you do, if there's this thing, especially this thing happens when there's contraction ongoing or when there is overdistension. Okay, so assuming that the woman is on oxytocin infusion during delivery and you are continuously monitoring your contraction rate. But when you monitor, you're not going to feel contraction. Meanwhile, there's oxytocin ongoing and you're not seeing any contraction. It's a problem. All right. Okay. If there is the woman is not even pregnant, there's overdistension from multiple gestation. Okay, there's overdistension. And once there's overextension, because you know that you are going to feel, you should feel fetal parts once the woman is pregnant. But you are not feeling fetal parts during your assessment. It causes for a problem. Do you understand, please?
Yes, please. Thank
you. All right. I hope you can continue.
So, please, I have one question. Can this rupture occur even without any triggering contraction? Like, if it's can just hyperdistension of the uterus cause a rupture without contraction?
Yes. That's why
Yes, please.
I said either it's resulting from contraction, ongoing contraction, or resulting from distension, over distension. Are you okay?
I'm
Meanwhile,
okay, sir.
the woman has not reached CS yet. Sorry, delivery yet, or labor. But because of over distension, it can cause rupture.
So is it predictable?
For with the multiple pregnancies?
Yes, sir. Like, can a physician predict it and maybe just program an elective CS because of predicted
Yes.
uterine rupture?
That's why we are saying that you have to identify your risk factors. If the mother has undergone CS, that's why even those who have undergone CS, we don't easily allow them to deliver. If let's say the pregnancy, the duration is so short, like you just delivered some few months ago, you are pregnant again. We don't want to have vaginal delivery. Okay, that's why they prefer CS, because the woman will be at risk, especially when there is contraction ongoing. And that's when we reach the transition phase, when contraction duration is so high and frequency is so like there's ongoing, the timing is so frequent. Okay, so this one is predictable. That's why you have to know the risk factors. Are you please okay?
Yes, sir. Thank you.
Okay. All right. So that is what we are going to know. But mind you, with this kind of bleeding, where are we going to see the bleeding? That's one thing that you should, latest on that you should pick up. Where are you going to see the bleeding? Know that there's going to be minimal vaginal bleeding. All right. So this case, the fetus will be at risk. Maternal shock, fetal death can occur. Fetal hypoxia can occur. Okay, because there's ongoing massive maternal hemorrhage. Do you understand? There's ongoing mass maternal hemorrhage. All right. So if it happens like that, know that it requires an immediate, what's the name? Immediate intervention. Are you okay, please?
Yes, boss.
So we are saying that as part of our intervention, if there's oxytocin ongoing, you have to what? Stop. Okay. And the most important thing is quickly you prepare for CS. Your priority, prepare for CS. Prepare for CS. That's your priority. Okay. Stop infusion. You prepare for CS. You give oxygen. Position. Okay. Large balls, especially in this case, I told you some time ago, whenever there's severe bleeding ongoing, the ideal thing is that you should have 2 IV lines. It's not ideal to have only one IV line because sometimes one IV line can be used for blood, and the other for what? Fluid. So ideally, when there's severe bleeding, please, one of your options should be what? 2 IV lines, and use large bore IV lines. That's 80, 20. Don't go beyond 20. 18, 20 is okay. Okay. And we have to continuously monitor the fetus. All right. Prepare for blood products and notify your healthcare provider immediately. Okay. So that is what you have to know. And complication is what? DIC. DIC. So DIC, take note of this DIC. Very common in most of the maternal emergencies. Okay. Most of the maternal emergencies. Because so far as I told you that, so far as there is foreign material running through the maternal circulation, DIC is a likely a complication. Are you please okay? Okay. All right.
Hello, boss.
Yes, please.
Please, talking about the intervention, would we say stopping the oxytocin is the first thing to do? Then preparing for CS is the priority thing to do.
Preparing for CS
is the priority, right?
If oxytocin is ongoing, quickly you have to stop oxytocin.
So that's the first thing to do during.
Yes. If the oxytocin is ongoing, you have to stop. And the most appropriate thing is to prepare for CS because it's an emergency. Emergency, I've always told you that in emergency cases, they need emergency management. Pardon?
I'm saying in case there's no oxytocin running, what's the first thing to do?
If there's what?
Is it to note there's no oxytocin running? What's the first thing to do? Is it to notify the provider or what?
Yes.
I think it will depend on the question.
If provider is there to notify, because in emergency cases where you the nurse doing something, look at all the options. Okay. When you, let's say you give blood or give what's the name? Fluid. Is it going to resolve the problem at hand? So in emergency cases, we need emergency management. So quickly notify your care provider to arrange for to do what? CS. So if it is for you to arrange, immediately report to this provider, please do it quick. That should be your priority. Or preparing the patient for emergency CS. And most times, they want, in most emergency cases, getting preparing for emergency CS or notifying the provider, they won't conflict that options. Okay, so either you are preparing for CS or you are notifying your healthcare provider. In emergency situations, they need emergency intervention. So giving fluid is not something important here in these emergency cases. All right, quickly notify. Giving fluid can come later, but it's not your priority here because the mother is dying, the fetus is dying. We need emergency delivery, and giving fluid is not going to solve the problem. Are you please okay? So always know that in emergency cases, we need emergency management. Are you okay?
Yes,
okay. So know your signs and symptoms. Sometimes you can see that with the bleeding, even sometimes the bleeding can be severe depending on the rupture. Okay. Sometimes you can have mass vaginal bleeding. Sometimes you can have minimal. Okay, depending on the right. So know that when there's rupture, when there's bleeding, shock is going to happen. What's the name? Signs of shock is going to happen because there's rupture pain. You can't rule that out. Okay. And that sensation, that tearing sensation. But know that if you want to assess fetal part, you're not going to see it by palpating the fundus. Okay. So know that. Okay. All right. Any other? But when this is occurring, we are going to see sign in the abdomen. Some of the signs in the abdomen. Okay. So we can just, yes, please.
Boss, please, you said that there might be minimal bleeding in the vagina. So the bleeding will be in the abdomen rather.
Yes. The bleeding can be in the abdomen. And most of the time, that's where we see the bleeding. Okay. Bleeding can be in them. Sometimes, if there's incomplete rupture, okay, incomplete rupture. With this thing, because the fundus is there, the uterus has not yet gone into the abdomen, okay, abdominal cavity, the peritoneum. So sometimes you can see bleeding through the vagina, okay. And most of the time, if you see complete rupture where all the content exits into the abdominal wall or abdominal cavity, that's where we are going to see the bleeding, most of the bleeding in the abdomen. And in this case, you see that we are having most of the abdominal. You can also have abdominal symptoms. Okay, abdominal symptoms in this case, like you see that the abdominal wall will be rigid, will be like a contour. Okay, and you're not going to feel palpation. We are not going to palpate fetal parts once we do a palpation because the content has been released into the abdomen. Please, okay. Are you okay? So if there's bleeding, do you have to? You give blood, right? So cross matching. Okay, you have to do your coagulation studies. All right, you have to do continuous fetal monitoring. All right, so that's what you should know. Okay, sometimes you can do ultrasound, but know that the most important thing is to prepare for surgery. Prepare for surgery. We don't want to delay surgery or notifying the healthcare provider in emergency situations. Are you okay? Are you okay, please?
Yeah, okay.
Right. Can this lead to PPH?
Yes. Yes, sir.
All right. So that is what you should know. Okay. All right. Let's try some questions here. If you have a nurse, okay, is working in a labor and delivery unit, is caring for multiple clients. Which of the following clients should the nurse prioritize? A client at 31 weeks gestation with ruptured membrane, foul vagina discharge, a temperature of 39, and chills. A client of 39 weeks gestation with painless vaginal bleeding and a fetal heart rate of 150. A client at 37 weeks with umbilical cord collapse through the cervix immediately after successful amniotomy. A pregnant client at 39 29 with a blood pressure of 150/95 and severe headache. Which one are you going to prioritize?
B.
B.
Yes, for me.
C.
Okay.
C.
A.
So we have all the answers
All
chosen. Mhm. Yes. Okay, let's analyze. A pregnant client at 31 with ruptured membranes. The membrane is ruptured. Foul vaginal discharge. Temperature of 39 and chilled. What is happening?
Inevitable abortion, then
What?
there's infect.
Chorioamnionitis.
Choreo.
Infection.
Chorioamnionitis.
Okay. The next one. 39. Painless vaginal bleeding. Peter heart rate was 150. What is happening here?
Previa.
Rupture uterus.
Is that?
I suspect rupture uterus.
Painless vaginal bleeding. Peter.
Placenta previa.
Yeah,
Okay.
placenta previa.
37. So we have previa. We have chorioamnionitis. A client at 37, umbilical cord prolapse through the cervix immediately after a successful amniotomy. So
That's the real
cord
deal.
prolapse. And 29 weeks with blood pressure of 150, severe headache. What is happening?
Preeclampsia.
Preeclampsia. Okay, so once you know the condition, which one are you going to prioritize?
Prolapse cord.
Yeah,
Cord
cord prolapse.
Cord prolapse, the C.
Cord prolapse. Okay. Umbilical cord prolapse through the cervix. All right.
But when it comes to bleeding, I say when it comes to bleeding, the fetus is at risk, the mother too is at risk. But for this umbilical cord, if we reposition the mother, knee chest position.
So what do you think is the answer?
Yeah, it would be because the danger is high between the mother and the baby, the fetus.
The B?
Yes, for me.
Okay. So B is bleeding, blood issue. Know that.
Yes.
A is infection. B is blood. C is what?
Respiration.
Oxygen.
Yes.
C. And D is what?
Preeclampsia.
Blood pressure.
All right. So that's blood. Okay. So the answer is oxygen. All right. You have to focus on oxygen. This one is ABC. All right. So ruptured membrane, that's infection. Someone with bleeding, vaginal bleeding, painless vaginal bleeding. Yeah, that's bleeding. And this one is oxygen, umbilical cord prolapse, fetal distress. Okay, oxygen. So as simple as ABCD. Are you okay, please?
Yes, boss.
A client with methicillin-resistant Staphylococcus aureus, Mr. SA, scheduled for gastric decompression. Which set of personal protective equipment is appropriate for the nurse to wear? This one there, I don't think is needed here. But you can try. Which one is most appropriate? Methicillin. Scheduled for gastric decompression. Know that. So what will be the PPE, appropriate PPE?
Gloves and gowns only.
Gloves, gown. Okay. Any other?
Gloves, gown, goggles, and face mask.
Yes, A.
Gloves.
It's A. Glass
Gown.
gown, goggles, and face masks.
Because there's gastric decompression.
Okay.
There is a likelihood of fluid splashes.
Yeah.
That's it. Okay.
A.
Is that what?
I said A.
Gloves, gown,
Goggle and face mask.
goggles, and face
Because it's a
mask.
contact
Gastric
precaution.
decompression. Okay. Gloves,
Contact.
gown. Okay. Why not C, but A?
Because they say only. That word
And
only.
only is a problem, eh?
Yes.
I think it's
Was Frank.
Yes, please.
Okay, so I think that if it's contact precaution, then you can just look at the C. But they also added that scheduled for gastric decompression. If it's the Staph aureus, then you can look at the C. But then they are saying gastric decompression, which means there's a risk of splash and all that. So you need to protect your orifices so that you don't get these organisms onto yourself.
Okay. So the answer is A. Okay. The next one. A nurse is
Please, sir, the answer is which one?
A.
Thank you.
A nurse is formulating a care plan. Postpartum client diagnosed with cystitis. I don't think these questions are needed. I couldn't select the appropriate persons here. Okay.
Please,
Let's
can you go back? I didn't get the answer. Sorry, sir. Can you please go back? I didn't get the answer for it. Please, what's the VP?
Which one?
I didn't
It's
get the
A.
answer. The VP. A.
A.
Please, why A? Please, why is it? Because I know it's contact precaution.
Yes, contact precaution. And contact precaution, it depends. Even if it's airway problem and it's airborne condition, one there's a possibility of splash. Okay, you go beyond that. Suppose if it's airborne we do wear our mask. All right, but when there's a risk of what? Splash, we go beyond that PPE. Are you okay? So you have to protect yourself. You have to protect the body because there's possibility of splash. You have to protect your eyes. Possibility of splash. Are you okay? Are you please okay? So, a 37-week pregnant client receiving oxytocin infusion develops late D cell on the monitor. What is the nurse's priority action? Administer intravenous fluid, apply scarf electrodes, reposition the mother, provide supplemental oxygen. Yes.
The answer is D, I think, because it shows that the placenta is not sufficiently supplying the fetus with oxygen.
Okay. Any other?
Yeah, D is the answer.
D.
Yeah.
Provide supplemental oxygen. Okay. I see.
Can say reposition. Of course, all agree.
Are you here?
Yes, we are here. Why do you see?
Do you know Lion?
Yes.
Yes. Lateral position.
Yesterday,
Yes.
you even made mention of it. So I don't know why the person said D.
Can you go forward?
Yes, sir.
Mhm. All right. So please, once there's uteroplacental insufficiency, okay, meaning the baby is not getting enough oxygen during contraction because the oxytocin is ongoing. Okay, so contraction is so strong that it's going to reduce blood flow to the oxygen, to the baby. All right. So quickly, you do position first. Positioning. You position before you go on to give fluid and oxygen. I place okay.
But Frank, this first action and priority is confused, you know.
It's
Because the
confusing.
question didn't say, yeah, the question didn't say the first action. It said priority.
Is that what?
It said next priority action. It didn't say first action. So I don't know. It's confused, you know. The first action and the priority.
I think.
Yes, so I think I agree with my sister in that when you look at the future, it seems to be like the uh, the L, which is the late deceleration, matches with placenta insufficiency too. So, and we know that in placenta insufficiency, mostly maybe the best thing is to also try to give oxygen. So I think that is where the problem is coming from. But it does make sense though that the answer should be the C. I understand too.
Placenta insufficiency, we don't always give what's the name? Is that oxygen, right? You have to know the cause. As we know, it could be result from what's the name? Hypertension. It could be result from preeclampsia, hypertension. Okay, so know the cause. Though we are going to give oxygen eventually if reposition doesn't solve the problem. Okay. And look at the word. It says receive.
I'm not okay.
Okay.
So I have a
Also
question.
not
Okay. In as okay, priority action is repositioning. But what if what I want to ask is there a case where you give oxygen and it doesn't go through, it doesn't solve the problem because repositioning has to be done first?
Yes. Every person is different. It depends on the case scenario that they give. Okay.
Can give oxygen and the airway is blocked, so it will not really have the impact on the patient. So position for the oxygen to go well.
Just then, know that oxytocin is being given. And what will oxytocin do? What will it do?
Contractions. To increase contractions.
Contraction. Okay, contraction. And once there's contraction, it means that blood supply to the fetus is going to reduce. Blood supply to the fetus is going to reduce. All right. And this patient is receiving oxytocin. If in this case, you have to stop the oxytocin. All right. And position the mother first. So are you saying you give oxygen in this case scenario, are you going to give oxygen first before you position? No. You position so that adequate blood flow will because it all has to do with blood flow. Blood flow. Once blood moves to the area, oxygen will follow. So the problem is blood flow, which is resulting in the deceleration. And in this case, once you do anything to increase blood flow before you give oxygen, are you please okay?
Yes, sir.
I'm not okay.
Yes,
Is
I'm
that
okay.
someone was saying something?
Hello.
Yes, please.
Yes, I want to find out as to what other position can we place a pregnant woman, because as far as I understand, the left lateral position is the most position that we have to place a woman. So suppose the woman is already on the left lateral position. If we reposition, which position are we going to take from? To the left side.
If the mother is already in that position, maybe from having issue, maybe you can go Fowler's position. Okay, Fowler's position will be okay. All right, but apart from that, it also depends on the case, because every problem has a way of positioning the pregnant woman. But in case of this issues, either left lateral, the are okay, not supine. Are you please okay?
Okay, sir.
All right.
But I don't.
The next is caring for a client who is in active labor, experiencing shoulder dystocia. Which action should the next take? Select order to apply. Apply suprapubic pressure. Instruct the client to push with contraction. Assist the provider with McRoberts maneuver. Perform fundal massage. Administer oxygen via face mask. Answers: yes. Quick.
C.
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 The question
C.
is select all that apply.
A is one of them.
Please, A.
C is
A.
one
Let's
of
be
them.
careful.
But we select all that apply. Can we select only one?
We can, but this one is not
If
only one.
yeah,
But
why not
this
only one?
place, the answers are more than
So far
one.
as
Yes, more
so
than
far as
one.
It
you are
cannot be one
confident
here.
of yourself that this one there I know for sure, you can choose that and leave that the rest, because if you choose a wrong option, it's going to be like a negative answer. 0. Okay. So you are saying what? C and what?
A.
A.
ACE.
A applies suprapubic pressure. C.
Yeah.
Assist the provider McRoberts maneuver. E. Oxygen. Okay, fundal massage is out. And okay.
They don't push with contract.
All right, so that is it. Okay. So that is
So, sir, the oxygen was actually passed.
yes.
Oh,
Yes, sure.
okay.
Okay. All right. Our time is almost up. Let's quickly run through this. Endometritis. Endometritis. Infection of the endometrium, inner lining. Okay. And most times occurs postpartum, especially after CS. Because after CS, there's going to be introduction of foreign material. And it doesn't matter how sterile the procedure was. The mother can still get endometritis. All right. After miscarriage, you know the content. Every place is dirty. The mother can get endometritis, inflammation of the endometrium, the inner lining of the. Okay, it can be as a result of PID or prolonged labor, especially if there's premature rupture, PROM. You know PROM, premature rupture of what? Membrane. And that's usually when it is happening more than 18 hours. So please take note of the time. When there's a rupture, the woman is seeing fluid coming through the vagina. There's rupture. The baby is coming. But it has been more than 18 hours. The baby is still not coming. All right. What is happening? There can be an ascending bacteria, which can cause an infection to the endometrium. All right. So that is what you should know. And once it happens like that, it can cause peritonitis or pelvic thrombophlebitis. Okay. So the first 24 hours postpartum, fever is expected due to dehydration. And what point do you say this fever is okay? Yes, fever. You say fever is expected. 24 hours. The first 24 hours, fever is expected. At what point of temperature do you say this temperature is okay? It's normal because it's expected. Yes.
Plus or minus 38 degrees Celsius.
38. Yes. So up to 38 is okay. But anything above 38 is a problem. Are you please okay? So check your temperature. If the temperature is up to 38, there's no problem. The mother is okay, document and go. But if it's above 38, it's an infection. All right. Fever. Okay, more than 38 after first 24 hours. All right. Uterine tenderness. Okay, because the uterus will be tender, very painful, but infection. And the mother is going to experience foul smelling lochia. The content that will be coming will be foul smelling, or sometimes reddish brown lochia. If it's bright red right after delivery, maybe the first 24 hours is normal. But if it tends to be foul smelling or reddish brown lochia, it's a problem. If there's going to be tachycardia, infection, fever is going to happen, tachycardia is going to happen. Okay. And if hypotension results, this endometritis is causing sepsis. Sepsis means that infection in the blood. This one is a systemic sepsis, systemic infection. Okay. But if there's no hypotension, in this case, you should restrict yourself to endometritis. But once hypotension sets in, together with fever, together with tachycardia, it becomes sepsis. Are you please okay?
Yes, sir.
So know your signs. You have chills. Patient will be malaise. Like signs of fever, signs of infection, lower abdominal pain, because there's infection, headache, okay, enlarged or soft uterus. That is subinvolution. The mother has delivered, but the uterus is failing to involute because there's infection. So what are you going to see with the fundus? It's very high. It'll be very soft. Know that it's going to be soft. of course. And not all softness indicates that there is what's the name? PPH is impending. Okay. So know that in endometritis, there can be softness of the uterus and sub-involution failing to go back to pre-pregnancy state. So the fundus is always higher than expected. Because there's infection, WBC very high. Okay. And ileus. What is ileus? Yes.
The bowel becomes let me say a loss of bowel movement or bowel sounds or absence of.
Okay. And there'll be prolonged severe after pain. Okay, after pain. And what is after pain? After pain. What is it?
Pain after delivery.
Pain after delivery.
Okay. And most of the times, especially if the baby is breastfeeding, okay, it happens like that. So because of endometritis, they're going to experience pain. Okay. Our priority in this case is to prevent sepsis because there's local infection. We want to prevent it from leading to what? Systemic infection, that's sepsis. So that's your priority. So how do you know the mother is having sepsis? Our vitals, especially with hypotension. Okay. So once we see tachycardia, we see hypotension, okay, unit output. All right. It should be less than. So less than or less than that is decreased. And if there's decreased renal perfusion, there's going to be decreased brain perfusion. Okay. Decreased brain perfusion. And decreased brain perfusion will lead to change in level of consciousness. Okay. So we have to administer antibiotics. Mind you, in this case, we place the mother in Fowler's position. Please take note. The best position to place a mother with endometritis is what? Fowler's. Because endometritis, there's foul-smelling discharge. And when we don't place the mother in Fowler's position, this foul-smelling discharge will accumulate in the uterus and lead to systemic infection. So we want to help drain the discharge. And the best position is to place the mother in Fowler's position. So mind you, in endometritis, the best position is Fowler's position. All right. And the mother needs private room. Although we are not going to isolate the baby can feed. Okay. But we need private room in order not to cause sepsis. All right. We have to also initiate contact precaution. Wear your glove, wash your hands. Because mind you, the mother has delivered fresh. All right. And avoid douching. Because these things, tampons and douching, rather cause more infection. So in endometritis, please, douching is not allowed. Tampons is not allowed. Limit vaginal examination. Vaginal examination. In endometritis, we limit it. All right. And hand hygiene is also important. And because of the after pain back rub, okay, we give pain meds. Do we give oxytocin or not?
Give.
We give. Why? Because there's what?
Help with contraction.
Involution.
So we have to give oxytocin to cause contraction. The uterus is bulgy, it's soft in endometritis. So we have to give oxytocin to cause involution. All right. So.
Hello, sir. Hello, boy.
Yes, please.
Why not standard precaution but rather contact precaution?
All right. That's a good question. Can someone help us?
I was about asking the same question.
Me too. Yes, who can answer? Yes. Yes, class. Hmm? Hello? Are we there?
Yes, we are here.
Please, let's answer. Any idea?
But Frank,
Yes, please.
yeah, I think it should rather be our normal standard precaution because it's not as if when there is any organism or whatever that when you touch it, you are going to infect yourself. Rather, it should be the normal standard, wear gloves and all of that. But contact precaution, I don't know why the contact precaution.
Okay. Do you know why
But
it's
Frank,
contact? Yes, please.
I'm also looking at it this way that when a mother goes through delivery and all those things, the mother has lost blood, so sort of they become immunocompromised, and there's already sepsis. So if you don't practice contact precaution and you expose the mother, you might introduce what do I say it, infections to the mother. That is what I'm thinking.
Okay. Thank you.
What our sister, hello, sir. I
Yes,
think what
please.
our sister recently said is rather reverse isolation, not contact
Yes,
precaution. That one should be rather be reversed.
best isolation, yes.
Okay. Any other?
Yeah.
Mm-hmm. Any other?
I think that is to protect the the nest. I'm just guessing
Hello?
because I'm just guessing that is because the mother she's infected, so the nurse has to protect his or herself. It's more about.
Okay. All right. Let's see if the chat box. Okay.
Right.
Maybe.
I didn't buy the paper.
Sister Poppy,
First, you are afraid. This one, Sam.
someone is
I didn't.
asking.
Hello, sir. I didn't ask
Please,
I didn't hear the question.
let's mute her, please.
Sam, where's
Sister
your
Poppy.
bread?
Sister Sarah Oparin. Please mute up. Sister Poppy, please. Mm-hmm.
I didn't hear the question, sir.
The question is,
The question.
in endometritis, we are saying, what precaution do we initiate? Is it contact or standard precaution?
Contact, sir.
Can you please help us? Why contact but not standard?
Contact because there is an infection, so that we don't exacerbate the condition.
Okay.
That is why the private room.
Okay.
Thank you.
All right. Any other?
Boss Frank,
Yes, please.
could it be the organism causing the sepsis at the time?
Organism causing the sepsis.
Yes.
That is one of them. That's one of them. Okay.
Because I know methicillin-resistant Staphylococcus aureus. So the patient came to the hospital and they went through delivery. It's possible that the patient is exposed to this methicillin-resistant organisms. So if that be the case, then contact precaution will be necessary.
Is that contact precaution necessary, right?
But
Yes.
in this case, no organism was mentioned here.
No organism is what?
I'm saying in this case, there's no organism mentioned here. So I think it should be a standard precaution, because I know that with contact precaution, like we use it if a client has a specific organism that spreads direct contact infection or something. Like
Okay.
what she said, the methicillin resistant Staphylococcus aureus.
All right. The whole thing is that, okay, wait, someone saying the infection isn't transmissible. One thing is that with endometritis, some of the organisms, it could be that the organism is as a result of STIs. Know that we have ascending ascending bacteria that will cause infection in the endometrium. I hope you are aware of that. That's why if you have prolonged rupture of the membrane, it can lead to endometritis, because there's going to be ascending bacteria that can infect the endometrium. All right. Apart from that, there are, let's say, patient is having gonorrhea, okay, or chlamydia. Can this lead to endometritis?
Yes.
So,
Yes, it can.
Can it lead to endometritis?
yes.
Yes,
Yes.
it can.
Yes. So these bacteria, okay, can also cause endometritis. And not only that, we can have, as someone was saying, methicillin-resistant Staphylococcus aureus, or even sometimes VRE. I hope you know VRE.
Yes, boss.
What is it?
Sister Eva, I'm quiet.
Vancomycin resistant.
Okay. All right. So all these things, or sometimes even some of the pathogens that they happen, especially if you are doing this thing, you are doing frequent vaginal examination. Okay, you are doing frequent vaginal examination. All right. All these bacteria that I'm mentioning will require contact precaution. We need to wear your glove. And mind you, standard precaution is just used anywhere. But once we have contact precautions, these bacteria that I'm talking about, this methicillin, Staphylococcus aureus, or vancomycin, this thing, all these things. So with this, together with gonorrhea, together with chlamydia, if the mother is having infection of all these things, or sometimes PID, Okay, the mother is having PID because of maybe chlamydia or because of gonorrhea. They can ascend and infect the endometrium. So in this case, we are going to use contact precaution here. Okay, so that is what you should know. But standard precaution is just something that we normally use in most of the in all, or not even most, all conditions. All right, but endometritis, please take note that we place the mother in a private room. That we place the mother in a private room. I told you about that. But we don't isolate the newborn. The newborn, we don't isolate, but we place the mother in a private room. We don't want to, because with endometritis, know that we are having body uterus. The uterus is not involuting. The mother is at risk of sepsis. Okay, and sepsis, if the mother is having sepsis, what precaution do we put? If someone is having sepsis, do we use contact precaution or standard? Sepsis. Do you know sepsis? Sepsis is one of the conditions that we use contact precautions. Are you aware?
Yes. Yes, please.
Yes,
Yes,
sir.
please.
Sepsis is one of the conditions that we use what's the name? Contact precaution. Please don't forget it. All right. And this condition, our priority here is to prevent sepsis. Our priority here is to prevent sepsis. So the ideal this thing is contact precaution. Are you please okay? Are you okay? Are you good? Or still
Yes,
confusion?
I'm confused.
But Frank,
Yes, please.
please, even though it's not what we are doing, please, can you really take us through what goes into standard precaution and contact precaution?
This thing there,
What's the key difference?
I think